So very good morning to all of you. And on behalf of Team IAP Mumbai, I welcome you all to this live, attenuated, extremely immunogenic, least reactogenic, and I'm sure by the end of the session, we will know the effectiveness and the efficacy also. This is vaccine, and the booster effect. So that we'll come to know in the next vaccine CME. So welcome you all to this vaccine CME with a difference 2024. And what is so different about today's CME? It's not just the old routine vaccines in question. The doubts and fallacies are always there in our mind. There is a lot of ambiguity to daily use of our routine vaccines. But what is also included this time is new vaccines on the horizon, which are upcoming to developing countries like ours, where a lot of vaccine preventable diseases need to be taken care of. Also different about the CME is, of course, the star faculty. There is an introduction of a very interesting quizzical, which is going to be a part of our scientific program soon after the lunch break. And of course, there is a different delegate bag awaiting all of you from IAP Mumbai, which is also going to be an added attraction. So without wasting much time, I welcome you all once again and wishing all the best for the scientific program today. I welcome Dr. Nitin Shah, sir, who is the main force and the scientific convener for today's program, to please come up, sir, and say a few words.
Well, delegates, I really admire your presence here early morning on a very nice Sunday, especially I'm sure half of you must not be sleeping yesterday night, and the remaining half must be busy posting on the social media. And I was conspicuous by my absence on the social media, which is something which rarely happens, is because I just slept off at 10 o'clock. So only when in the morning I got up, I saw the news. Anyway, I think this is the second year we are doing this vaccine CME. Last year we had the run-of-the-mill common topics. And this year I thought we will have a different CME where we have only vaccine not available in India. But then I thought probably that may become too boring for delegates who may be interested in practical solution in the day-to-day practice. So we decided to have a hybrid whereby monologues will be generally on the newer vaccines going to be available soon, and the dialogues will be taking care of the day-to-day problem that we face in our pediatric practice. So we have a galaxy of speakers, and I'm sure, Dr. Kasi, everyone knows he's my vaccine guru, as I always say. And we have other people who have traveled from length and breadth. So Dr. Pankaj Garg will join us soon. Dr. Manish is there from Aurangabad. And we have our local faculty. All of them would enrich us with the knowledge about this newer vaccine and the day-to-day problem that we face. And I hope the delegates will take back a lot of scientific messages besides the good food, the good venue, and the very unique delegate bag. So you have to collect 2 delegate bags. One is the routine delegate bag like our routine vaccine, and one is an interesting bag which is like the newer vaccine that are going to come. So that is not happening now because we don't want anyone to spend time doing that when the science is being discussed. You can do it during the tea break, right? And thereafter any time from the IAP stall and the stall next to it. So you'll collect 2, one a bag and one another gift hamper for all of you to take back and have sweet memories of today's CME. I cannot end without thanking all the sponsors, because we have been doing this CME in always a little grandeur type of environment, unlike a lot of other CMEs we do, which are like low cost type of events. So this could not be possible without raising money. And for a one-day conference to raise money is not that easy. But whatever advantages I have in the vaccine field, I could use those to get enough money. So we have all the sponsors who have really helped us in a big way by supporting without questioning on one single email, and in 48 hours the budget was sealed. And Mir Shaya Bhai is there from Bharat Biotech. He's a very dynamic person in Bharat Biotech. Though he's not a doctor, but you will see he'll sit through the entire day learning from all of us. So thanks all the people who are here from the sponsors side. And we will start the CME now and have the first session. Thank you very much. Yes, and besides the 2 hampers that we have also vaccine-specific goodies. But they will be available from the respective stalls. So please do visit the stalls and collect those goodies. They are not like pen and pad that everyone gives. These are like day-to-day practice-oriented goodies that you will get from the other stalls. So there are only 9 stalls, so just visit each one of them. It also boosts up the morale of the people who are manning the stalls. Also, you should not lose on the goodies which are helpful in your day-to-day practice. So hand over back to the MOC today.
Thank you so much, Nitin Shah, sir. So when it comes to the vaccine CME in the year, IAP Mumbai is completely relaxed with Dr. Nitin Shah at the helm of affairs, because it is always a man with a Midas touch. And when sir says vaccine CME karwani che, so it is going to be done, and it's going to be done in a big way. So thank you so much, sir. And now I invite our 2 very young, dynamic, very bubbly, chirpy EB members of Team IAP Mumbai 2024, Dr. Jagruti Sanghvi and Dr. Reepa Agarwal, to please come up and lead the proceedings. Thank you.
Good morning, respected seniors and dear colleagues. It's indeed heartening to see you all on a Sunday morning after an exhilarating, adrenal-rushing ICC T20 World Cup victory by our Indian cricket team for a vaccine CME. For most of us, vaccines are our bread and butter.
And sometimes vaccination is our jam and cheese spread too.
We all know our IAP immunization charts verbatim. So what more does IAP Mumbai plan to offer us today?
Well, as already mentioned by Nehal Madam and Nitin Shah sir, that today's vaccine CME is not an ordinary CME.
Oh, really?
Yes, because D for Dosto, presenting to you today's vaccine CME with the D for difference by the dawns of vaccinology.
And there are D for thus individual sessions with D for discussions galore by our D for distinguished faculty.
And together we will learn how to prevent the D for deadly diseases, clear our D for dilemmas, and we are also going to have a Dhamakedar quiz in this digital age with a Mentimeter, and not to forget the D for delegate bag and the goodies.
So, D for Dil Tham Ke Baitho. A warm welcome to all our D for delegates in this D for delightful feast of knowledge, coupled with D for delicious meals at this exotic D for destination at Hotel Sahara Star, and of course on the eve of D for Doctor's Day. So happy Doctor's Day to everyone here. And yes, we definitely deserve D for deserve. A round of applause for this.
Thank you.
They say that prayers go up and blessings come down. So we can't do away without prayers to Mata Saraswati. So just saying a small shlok for starting our day on a very positive, auspicious note. Ya Devi Stutaye Nityam Vibudhairvaida Paragaihi Same Vasatu Jivvagre Brahma Rupa Saraswati Saraswati Namastubhyam Varde Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada Hari Om. So let's start our CME with a disease that is as old as mankind, malaria. A disease that has been biting us all, black and blue, since the Mesopotamian age. But it was only in the turn of the 19th century, and actually in 1897, that Sir Ronald Ross discovered the malaria vector, which is the Anopheles mosquito. A doctor cum poet that he was, Dr. Ronald Ross, in 1890, expressed his frustration at the inability to discover how the spread of this deadly disease is occurring in his poem called as Indian Fevers. He said, "The painful faces ask, can we not cure? We answer, no, not yet. We seek the laws. Oh God, reveal through all this thing obscure the unseen, small, but million murdering cause. So he, way back in 1890, called this the million murdering cause. And now, after 125 years, we are as yet at another breakthrough, the invention of malaria vaccine. And our opening batsman today is the most learned, eloquent, and the man with crisp knowledge, Dr. Kasi. He's going to talk about it bites and breaks, but let's not give malaria a biting chance. I invite Dr. Srinivas Kasi, consultant pediatrician, Bengaluru, the past president, IAP Bengaluru. He has had numerous respected positions in ACVIP and IAP Committee of Immunization, as we all know. To a crowd that is interested in vaccine, Dr. Kasi is not an unknown name. He's contributed various chapters on vaccinology in various IAP textbooks. It's indeed our honor to have Dr. Kasi amongst us today. So let's welcome him with a big round of applause.
Good morning. Thank you. Glad to note everyone is awake and raring to go. At the outset, my sincere thanks to Dr. Nitin Shah and the team of this Vaccine CME with a Difference for inviting me here and giving me the honor of being the opening batsman. It's also very nice to know that we are not dealing with very routine topics. We are dealing with vaccines which are probably going to enter clinical usage in the very near future, probably by next year end. So let's begin with something that bites us and breaks us. Well, no prizes for guessing what it is. We are going to talk about malaria vaccines. Malaria is still endemic in 85 countries, down from 103 in the year 2000. So there has been a reduction in the incidence of malaria due to non-vaccine measures, which I will not go into detail right now. In the year 2022, there were an estimated over 600,000 deaths due to malaria and over 249 million cases of malaria. Of these, 94% occurred just in the African subcontinent. Southeast Asia accounted for just about 2%, and of this 2%, India topped the list. We accounted for 66% of all cases. So a definite problem in our country. As far as childhood malaria is concerned, almost 3/4 occurs in children below 5 years. And somehow this ratio has remained unchanged for the past almost 20-25 years. Coming to India per se, this is data from the year 2001 till 2022. Cases have declined from 2.09 million down to 0.19 million, a very dramatic fall in reported cases. Falciparum has reduced from 1 million to 0.12, almost a 90% fall. On an average, about 1,300 deaths every year, except for the year 2006, where there was a massive outbreak of malaria in the northeast part of our country. The slide positivity rate, which is one of the measures of the incidence of malaria, has declined from 2.31 to 0.19, and the falciparum positivity rate has declined from 1.11 to 0.12. So a 90% decline in all parameters regarding the incidence of malaria. So basically, the overall endemicity is reducing in our country, though this may not be true for other parts of the world. We all know about the Plasmodium life cycle. There are basically 3 stages. The first stage is in the liver, the second stage is in the blood, and the third stage is in the mosquitoes. So all our vaccines are also directed towards these 3 stages. So we have pre-erythrocytic vaccine, that is dealing with the liver stage of the Plasmodium life cycle. Then we have the blood stage vaccines, none of which are still in clinical usage. Then we have the transmission blocking agents, which are still in infancy. None of them have even reached beyond stage 1. Now, the problems with a malaria vaccine is it's a huge organism compared to, say, many other viruses or bacteria. So there are thousands of antigen. It goes through different phases, and at each phase, different antigens are exposed. Moreover, like all microorganisms, the Plasmodia has evolved many mechanisms to evade the human immune system, so that it's basically an instinct for survival. So of all these, which is the one which is useful as a target for vaccines? That has been a very crucial issue, and that has hindered the development of malaria vaccines. In spite of that, there's a very thriving, robust malarial vaccine pipeline. We have about 133 vaccines in clinical development, undergoing 221 clinical trials. 196 have been completed, 24 have been ongoing, 1 has been withdrawn. Please look at this. 96 of these 133 have become inactive for various reasons. Most probably they haven't worked, or the reactogenicity, etc. 95% are targeting falciparum. Only 4 or 5 are targeting Vivax. This is of relevance for our country. Almost blood stage and pre-erythrocyting are almost equal, head to head. Very few for the sexual stage and the mosquito stage. Various platforms are being used. Numerous subunit, VLPs, and recombinant, etc. Various target antigens, of which the CSP, the circumscribed protein, is the one which is the most utilized antigen. Various types of adjuvants are being used. And of all the trials, the vast majority have been done in Africa, because that is the continent with the maximum burden, and it's predominantly falciparum. See, the issue with Africa is well-defined falciparum zones, which does not exist in our country. Here we have falciparum and OVL and even Vivax occurring in the same geographical area. So giving a vaccine for only falciparum, how relevant is it for our country? We'll deal with that a little later on. So only 2 vaccines have entered the clinical stage. One is Mosquirix, and by GSK, and the second one is the R21, which is in fact being developed by Serum Institute. Mosquirix is being developed by Bharat Biotech in our own country. So I'm going to deal with only these 2 vaccines. Mosquirix is based on the circumsporozoid protein. If you look at the genetic structure, we have a region which has B cell epitopes. We have a region which has T cell epitopes. So what have they done? They have isolated the gene. Using molecular scissors, they have taken a part of this B cell. They have taken a part of these T cells. And using molecular adhesives, they have combined it to one 266 amino acid sequence of HBsAg. To that mixture, they have added an excess of HBsAg. For your information, in the product insert, this particular vaccine is licensed for use for prevention of malaria and hepatitis B. There's so much of hepatitis B surface antigen in this particular vaccine. And why is it called RTS, S? The first R starts for this NANP repeats. So repeats, T cell, surface antigen, and the second S stands for the excess HBsAg. So this is the nomenclature, RTS, S. Now, how is this vaccine made? You take the genetic material of the CSP protein. Whatever we want, I told you that NANP and the T cell episodes. Using ligases, you bind it to the hepatitis B surface antigen, so you get this sort of a recombinant protein. You insert that recombinant protein in a plasmid. You insert that plasmid into a transmission system, which in this case is Saccharomyces cerevisiae. By electroporation, you put it inside. It multiplies, It forms a large number of this recombinant protein. It is then purified, you get your vaccine, and as far as Mosquirix, the vaccine and the adjuvant are separate, you need to combine them before giving the vaccine. So each dose contains about 25 micrograms of the antigen AS01E, which is a very unique GSK adjuvant system. It is indicated according to the product insert for active immunization of children aged 6 weeks to 17 months against malaria caused by P. falciparum and hepatitis B, as I just told you. 3 doses, 0.5 ml at monthly intervals. A 4th dose is recommended 18 months after the 3rd dose. However, for programmatic purposes, the vaccine is usually given after the age of 5 months. Now, this vaccine was studied in a large phase 3 study in 2 age cohorts, 5 to 17 months and 6 to 12 months, 11 centers, 7 sub-African countries, sub-Saharan African countries. They were followed up for a minimum of 48 months and the younger infants for 38 months. The primary endpoint was efficacy against clinical malaria over 1 year. Secondary included what is as of a booster dose. Additional analysis during the extension phase looked at other parameters as well. This in briefly describes it. The vaccine was less effective in those between 6 and 12 months versus 5 to 17 months. The efficacy of the vaccine was greatly improved by the addition of a booster at 18 months. Taking these into consideration, we must remember that at best, against clinical malaria, the efficacy is about 36.3% only. But what are the spin-off benefits? This vaccine reduced severe malarial anemia by 61%, the need for blood transfusion by 29%, and malaria-related hospitalization was reduced by 37%, all statistically significant figures. So though the efficacy against clinical malaria per se was not really very impressive, the spin-off benefits are something that is going to give rise to a lot of public health benefits in the use of malaria vaccines. A vaccine against malaria cannot by itself be a preventive measure. It has to be combined with other measures. So the study was done in an area where there was a seasonal transmission, where only vaccine, only seasonal malaria prophylaxis versus the combined. And what they found was combining definitely was more efficacious than using a single measure. So today RTSS has been introduced in African subcontinent combined with insecticide treated nets and seasonal malaria prophylaxis where it is applicable, especially in countries where there is seasonal transmission. And that is the role of the vaccine, and it's not an isolated role for prevention of malaria. Now, this vaccine has been followed up for 7 years. At the end of 7 years, the vaccine efficacy had reduced dramatically. So the efficacy is very, very less. And what was found that once the vaccine efficacy reduced, the incidence and severity of malaria rebounded to higher levels in the vaccinated host. But this was not a public health issue because this occurred at a time, at an age when malaria is not really an extremely serious illness versus the infants, where the mortality and morbidity rates are highest. So in spite of this rebound, this is still a very good public health measure. During this phase 3 trial, 3 or 4 very significant adverse effects were detected. One was meningitis, generalized convulsive seizures, cerebral malaria, and increased mortality, especially in females. There were no vaccine-related deaths. So with this sort of adverse effect, you could not use this vaccine on a more regular basis in a wider population unless we were sure that these adverse effects are not very, very significant. So based on that, in 2016, the malaria vaccine implementation program came into play. So the main aim was is it safer? how effective is it at the population level. And this was introduced in 3 countries, 4 years, where a large number received 1 dose, 2 doses, 3 doses, and a significant number received the booster dose as well. So looking at the adverse effect profile, if you in the phase 3 trial, the relative risk was very high, 10.5, 2.5, 2.61. But when this was re-examined in the MVP, it had come down to below 1, indicating that there is no risk for any of these adverse effects, and why they were detected in the phase 3 trial were due to extraneous factors and not due to vaccine inherent factors. Next, what was the efficacy of this vaccine at the field level, at the population level? So, when different parameters for severe malaria was used, the efficacy ranged between 30 to 35%. All-cause mortality reduced by about 7%, though it crosses 0. Hospital admission for any cause reduced by about 8%. Positive malaria test 21%, severe malaria anemia by 22%. So there was a very significant benefit even at the population level. So I said there are 2 vaccines. Now let's come to the second vaccine, which is the R21 Matrix-M vaccine. This is the second vaccine which has now been authorized by the WHO for use in malaria endemic countries. Very similar to the previous vaccine, the same manufacturing process, except that there we used Saccharomyces cerevisiae. Here we are using Piscia pastoris. This is basically a less expensive system. So this has been used for R21 vaccine. And in this vaccine, the adjuvant and the vaccine antigen are combined together. So you get a prepared product versus Mosquirix, where you had to mix them separately before you administer it. And the difference between these 2 vaccines is, while Mosquirix had an excess of HBsAg, this vaccine did not have any excess of HBsAg. So the thought is that somehow that excess HBsAg was retarding the immune response to the recombinant antigen. So when you remove that, somehow the efficacy seems to have increased. The 12 months efficacy for this vaccine showed a very good response of over 75% at the seasonal sites, that is where there is seasonal transmission. At the standard sites, 67%, overall about 72%. There was some waning of immunity at both the seasonal and standard site, and as expected, the efficacy was higher in the older age group compared to the younger age group. But a word of caution, this is only follow-up till 1 year, whereas Mosquirix, I spoke about 4 years, 5 years, and 7 years. So let's not be carried away that this is a much better vaccine. Unless this vaccine is used at a population level, I think it would be unfair to compare these 2 vaccines. Right. The rate reduction, see, this is where the benefit is in developing countries, where there's a high burden. It is not the absolute numbers of efficacy, it's the number of cases that you prevent, the number of deaths you prevent, the number of transfusions you prevent. That is what is of crucial importance in a developing country, in a hyper-endemic region. And as taking those things into measure, there's a very, very significant reduction in the burden of malaria with the use of this vaccine. Good immunogenicity, and immunogenicity response was much higher in the older age groups compared to the younger age groups. There has been a decline in efficacy from 80% to 67% within 1 year, and at standard site from 79% to 63%. And between the seasonal and standard sites, there was really no significant reduction in the decline. Safety-wise, very well tolerated. Some amount of injection pain and fever were the most frequent adverse effects. And basically, the serious adverse effects did not really differ much in the vaccine and the placebo groups, and there was no treatment vaccine-related deaths at all. And on 2nd October 2023, last year, WHO recommended this vaccine as a second vaccine for the prevention of malaria in children. And as of now, April 2024, 8 countries in Africa offer malaria vaccine as part of the childhood immunization program. At least 10 more countries are likely to follow with these 2 vaccines, and at least 30 countries are planning to introduce malaria in their NIP. something that will go a very, very long way in reducing the burden of malaria. Now the question is, should we utilize this vaccine in our country? I think that is what we are most eager to learn about. The WHO has categorized India as a very low transmission setting. And this vaccine is recommended only in high and medium-high transmission settings. Now, basically, there are certain definitions for calling it as a low or very low or high transmission region. And this is the PF, that is Plasmodium falciparum prevalence rate, and API, the annual number of new falciparum cases between the ages of 2 and 10 years in a particular year. So, just taking these figures into consideration may not be very correct, because our surveillance system for malaria is not really very optimal, unlike polio. We have a rather weak public health system, and that may probably undermine the burden of malaria in our country. And as I said earlier, we do not have exclusive falciparum and exclusive vivax areas. We have a conglomeration where in the same region you have 3 or 4 strains of malaria which are circulating. So basically, this Mosquirix has been shown to be cost effective in a scenario where the PFPR is at least about 10 to 25%, and this API is 250. In our country, the API is just around 44, and based on that, we are really not eligible, and probably the vaccines will not be very useful in our country. So, what is the type of malaria vaccine that we should have? It should effectively prevent the first stage of development in the host. It should block further stages from developing, that is, a sporozoite should not become merozoite should not become reach the sexual stage, and it should prevent transmission. So, whatever, there should be no malarial parasite left in the human due to the vaccine for a mosquito to ingest and infect another human being. So, these are the requirements of an ideal malaria vaccine. A far-fetched dream, but what we have today, according to the WHO product profile of at least 50% efficacy, we are somewhere near it as far as the available vaccines are concerned. Thank you.
So we begin with our first vaccine dialogue, Bomb It. So this is really not going to be very dangerous. It's all going to be in a very light way. And I'm sure all the panelists are going to do us a great work. So beginning with our first vaccine to be discussed in this session is on WB priming. So the first question for the audience, which according to you all is the most immunogenic? All 3 doses of AP at 6, 10, 14, all 3 doses of WP at 6, 10, 14, WP priming followed by AP at 10 and 14, and AP priming followed by WP at 10 and 14. Quickly, 1, 2, 3, 4, audience. Everybody for 2? So, yes. Yes. So sir will tell us more about it in his lecture. Okay, so we agree. Nahi, humko nahi chahiye. So we agree that the answer was 2, and let's justify this with our panelists. Regarding immunogenicity and reactogenicity, because these are the 2 things that we discuss when we are looking at one over the other. So, Dr. Vijay Yevle sir, is WP more reactogenic compared to AP for local and serious systemic adverse effects like the HHS syndrome, inconsolable crying, hyperpyrexia, encephalopathy, and seizures?
Yes, WP vaccine as compared to the acellular pertussis containing vaccines are definitely more reactogenic, especially for the commonly seen local reactions like lump, pain, swelling. These are less by almost 2/3 with acellular pertussis vaccine. However, the other reactions that Nehal has mentioned, like HHE or inconsolable crying, hyperpyrexia, encephalopathy, etc., are as such not very common even with DTWP vaccine. But they are 10 times less common with acellular pertussis vaccine. And this has implication with respect to acceptance and vaccine coverage. So, to control a disease in public health, you need to have a very high vaccine coverage. So these are the, if you remember, earlier the DTW vaccines were easily accepted and the disease burden started coming down. The focus shifted from the disease to the adverse reaction, and people stopped accepting. And that is how the acellular pertussis vaccines were invented. So definitely these vaccines are superior in terms of reactogenicity. In terms of immunogenicity, I think we'll
Both for
talk
local
about
and serious systemic
local
side
and serious
effects, your cellular will score a little more as compared to
Definitely,
the WP.
definitely.
So does occurrence of these contraindicate further doses of WP, Praveen sir?
This definitely does not contraindicate further use of WP. There are only two main contraindication for WP usage. One is the anaphylactic reaction following a WP vaccine, and the other one is encephalopathy occurring within 1 week of the vaccination when no other cause is attributable. Whatever is mentioned here, like HHS syndrome, inconsolable cry, hyperpyrexia, all these are precautions. So, however, if the patient is affording, one can shift the second and third dose to AP vaccine to reduce the chances of this kind of reactions. But knowing fully well that even with AP it can occur.
Right, sir. And also, does the literature say that with subsequent doses, even these reactions become lesser and lesser? So if you're taking subsequent doses of these, maybe the severity of the reactions that has happened initially may go down. So in both the purposes, you don't really contraindicate the use. Let's go to the other part of the immunogenicity. So, Praveen Gokhale sir, would you discuss the immunogenicity factor in between the WP and AP, vis-a-vis?
Yeah, immunogenicity is a...
Sir, could you first also say what is immunogenicity? Because all of these look so similar to us as general pediatricians.
Immunogenicity is nothing but the process of evoking humoral and cellular based immunities where the B cell and T cell get activated, and that is the start of the immunogenic process. So it's basically a process where the fresh antigen is introduced and we study it with the follow-up of the immune response to it. So that's immunogenicity.
So regarding WP and AP, we have to discuss in between which is more immunogenic compared to the other.
Definitely the wholesale vaccine is more immunogenic than the acellular pertussis vaccine because of the peculiar type of immune responses that are set up by the TH cells. So it's a more strong, potent stimulator of the cell-mediated and the memory cells as compared to the acellular pertussis, partly because of the nature of the antigen that is introduced. Here you are introducing the whole cell, that is the entire bacterial load, and in the acellular you are fractionating into smaller antigens where the molecular weight reduces, so it does not stimulate to that extent as the whole cell.
Praveen Mehta sir, efficacy?
Efficacy is the ability of the vaccine to prevent the disease in a particular person.
Individual.
Immunogenicity, as he has rightly said, is the ability to produce antibodies, but whether it will protect or not will depend upon the efficacy.
So in between WP and AP, efficacy wise also WP would be higher compared to AP?
If you look at the initial 5 years, both are same. If you look at the longevity of the protection, WP is any day better.
So this is an important factor that in the first 5 years, they both are similar as far as the protective efficacy to an individual is concerned. And Vijay sir, effectiveness.
So a bit of correction, immunogenicity wise, I would say all vaccines are equal, whether WP or AP. It, as Praveen Bhai said, in terms of longevity, let's not forget that even with natural disease, the pertussis immunity does not last lifelong. So with the waning is little better with wholesale pertussis, it lasts little longer. And the immunogenicity wise, as Praveen said, the immune response is tilted towards Th1, Th17 type of response, which elicits tissue resident memory cells, which are responsible for clearing the pathogen from the mucosa. And they also recruit neutrophils on re-exposure. So, and this has been proven in mice and baboon. And if you look at the WHO position paper, said that there needs to be some more robust evidence in human beings. Having said that, all in all of us know that both are immunogenic. The waning is little less with wholesale pertussis as compared to acellular pertussis. However, acellular pertussis containing vaccines are far more less reactogenic, so acceptance is better. So from public health point of view, vaccine acceptance and vaccine coverage are extremely important. Now, effectiveness is something which when a vaccine is, which has been tried and tested, but it is put to use in real life, the ability or the measure of the control of the disease in community is referred to as effectiveness. And the effectiveness would depend on the efficacy plus the vaccine coverage that one
Absolutely.
achieves.
So sir has also taken the next point, which is waning of immunity, and as Dr. Praveen Gokhale pointed out, that the response with a WP is more stronger, more sustained, and more longer compared to AP, right sir? So that's regarding the waning of immunity, which happens of the AP waning happens a little more earlier as compared to the WP waning. Regarding the herd effect, sir. So Dr. Praveen Mehta can take it.
A herd effect is the population of the people who are not vaccinated but gets definite
Protected.
advantage because of the blockage of transmission to a group which has been vaccinated.
Right.
So a classical example is when the pneumonia vaccine was, pneumococcal vaccine was introduced, PCV7 in USA, they found that even so many elderly people who were not vaccinated, the number of cases went down, and this is a classical example of herd effect.
So would that be different for both WP, AP, the herd immunity?
Definitely herd effect will be better with WP for the simple reason, as Dr. Vijay said, that it has a Th1 response which produces a higher quality antibodies, that is type 1,
IgG1.
type 1, IgG type 1, and it also kind of raises to a very high level, and it's an
Stays for the
opsonophagocyting and neutralizing antibody. That's the advantage with WP. So it clears the nasopharyngeal carriage and helps in prevention of transmission, unlike in AP vaccine.
Right, sir. Thank you, sir. So the next question is answered. What are the functional differences in the immunological memory induced by primary or booster vaccinations with WP and AP versus AP? So as they rightly said that with WP, the responses are with Th1 and Th17 as compared to AP. And that is why the IgG1 response is better with WP, which gives you a longer lasting and a more sustained effect as compared to with AP, which is IgG4, which has lesser neutralizing antibodies. So the big question, sir, Vijay Yevle sir, so how do we prime now, WP or AP?
Now, all this emerged when there was a big hue and cry about the scattered outbreaks that occurred early in 2010, 2012. And various outbreaks it was not uniform, it was seen in a few countries. And mind you, outbreaks occurred even in countries which were using the wholesale Pertussis vaccine.
Right.
Now the certain outbreaks were studied, and there was a big paper which was published which talked about the breakthrough pertussis in children who were vaccinated between 1999 and 2011. So what they realized, the pertussis was least seen with children who had received the entire series with wholesale pertussis containing vaccine. The next better was those who had received 1 or 2 doses of wholesale pertussis followed by acellular pertussis. Third best was all acellular pertussis, and fourth was acellular, least response. I mean, most of the disease was seen in children who had received AP first followed by WP. But one must also remember that this was not a head-to-head comparison in the same age group, same population at a fixed period of time. A child, imagine, who received WP vaccine in 1999, the coverage that time was definitely less as compared to what it occurred in 2010 or in later years. So there was a better opportunity for natural boosting. Secondly, the children who received wholesale pertussis vaccine in 1999, in 2011 they were the eldest of the lot. And as the age progresses, as you grow, the pertussis attack rate as such comes down. So to conclusively say that it is the wholesale pertussis vaccine which protected these children against recurrence of pertussis would not be absolutely fair. I mean, it is not it is comparing two vaccines in different period, in different age group and over different period of times.
Sure,
So-
sir. So, with a quick revision of what our panelists have given us, when we compared the WP and the AP vaccines as regards priming, definitely WP is a little superior in different studies all over the world, including India. Duration of protection is longer compared to AP. Herd effect is documented in WP as no herd effect documented in AP. Minor adverse reacts are almost the same. Serious adverse reacts are very rare in both the groups. Acceptance is good both the ways. Globally, of course, acellular pertussis is more because it is less reactogenic as compared to our country where the acceptance with WP is also good. And this table shows us very beautifully that with a natural infection, if the median range of protection is 8.5 years, it is definitely significantly a little higher with WP, which is 8 years, compared to AP, which is about 6 years. So the observations out of this come out as AP vaccines may be more effective than WP vaccines with the lowest efficacy. However, they are less effective than WP vaccines with the highest efficacy.
I will only add, madam, one point that
Yes, sir,
most of the WP vaccines which are available today in our country, they are all high efficiency.
High efficacy, yes. So they are definitely more immunogenic. The lowest pertussis reporting in pure DTWP primary series, followed by first dose DTWP results in lower pertussis. Sir, I can't. Sir, this is very uncomfortable. Sir, this is really uncomfortable. Sir, this is too high. No, sir, Okay. Sir, 5 more minutes, sir, for this break. Yes, thank you. So, first dose DTWP results in lower pertussis versus pure DTAP course and mixed course with the first dose as DTAP. So the key messages would be primary course with DTWP offers long-term protection. Even first dose given as DTWP priming makes a difference. Interesting facts, humans are the only host species of the violent or the 100-day cough, and cases in chimpanzees and wild gorillas have been reported due to close contact with humans. So let's
Nehal,
go
I would only like to add one
Yes,
point.
sir.
Let's not go home with the message that AP vaccines are inferior. What is required for control of pertussis is high vaccination coverage. If you are able to ensure that the child takes all primary AP, the first booster, second booster, and the 10th Tdap, this child would also be equally protected. But I'm not saying that you for this reason you shift out to AP. Those who are comfortable taking wholesale pertussis vaccine, give them wholesale. There is no need to change out to acellular pertussis. I mean, somehow the tolerance in Indian children appears to be very good, and they are comfortable and pretty happy taking WP. You should aim at increasing coverage and ensure that every child takes this pertussis containing vaccine as per the prescribed schedule.
Dr.
I
Praveen
just
wants to add.
add a point that both, see, only the antibody response may not mean anything. Both WP and AP require boosters.
Right.
That is true. And second point regarding the herd immunity, in India, maximal usage is of wholesale pertussis, even if we give in private practice acellular,
Right.
but most of the population takes wholesale.
Yes.
And we have not seen any significant major outbreaks
Right.
in either of the groups which are taking the vaccine. So I think they are both giving
Closely
protection,
and individual. Sure.
provided you keep up with the boosters.
Sure. So moving on to the next, which is rotavirus vaccine. So again, a question for you audience. Khushbu has received her first dose of rotavirus vaccine at 14 weeks outside and comes to you at 6 months. Start the entire 3-dose series again. Rota can't be given after 6 months of age. Give 2 additional doses of Rota at an interval of 4 weeks. Quick. Third. Okay, so there's a unanimous third. Everybody.
Only
is
one
getting-
correction, madam, that if they Khushbu had received RV1, then I'll give 1 dose.
Yes, yes. So yes, absolutely. We'll come to that. So, Dr. Sir, you can take this. Is monovalent RV1 superior or pentavalent RV5? Dr. Praveen.
Yeah.
Both are same because there is a lot of cross protection in rotavirus vaccine.
Right.
So,
So-
there is no this is superior or that is superior.
Okay. So with Rotarix and a Rotatech and a Rotavac and a Rotavac 5D and a Rotasure, it's all the same. Either you take a monovalent RV or you take a pentavalent RV1. Yes, sir. You need to say something, sir.
Yeah, technically, I think there have been some studies which have shown that the pentavalent vaccine shows a better and a longer sustained immunogenic and protective potential. But the target of the rotavirus vaccines is the protection in the first year where all the vaccines co-equally.
Right.
No,
So
I would like to correct this. See, when the RV1 monovalent vaccine was used in Brazil, the circulating strain was G2P8 and R1 is G1P8. And the circulating was G2P4. That was the main strain. But still, the effectiveness is excellent. So there is no doubt that even the monovalent RV1 is extremely, useful and effective in controlling rotaviral infection, regardless of the strain that is in circulation. Number one. Number two, RV1 is supposed to be a little more human friendly. So technically, the risk of intussusception or adverse events or the vaccine take is technically better with the RV1.
Right, sir.
Otherwise, all rotavirus vaccines in terms of efficacy, effectiveness,
In fact, the beauty is that with a single rotaviral shot also, for the subsequent infections, the person is already having a little cross immune protection and the immunity goes higher and higher with the second and the third dose. And that is why a monovalent also protects you from the other strains as well over the second and the third dose.
Absolutely.
See, there is another company also which has a human strain, that
Yes,
is Bharat Biotech, and which
Right.
is also
Welcome.
from neonatal
Yes, sir,
particularly.
that will come. So intersusception was worst with Rotashield, which was withdrawn. Thereafter, with these, there is not, sir. Are there any Indian studies?
No, I said no. There are no studies documenting that they are more with other vaccines except the Lederle vaccine. No.
And also
I said
that
technically it is. No, it is not. You take any rota vaccine and there is no, the
Increase.
benefit accrued is far, far more than the negligible risk of intussusception. And intussusception today's era can easily be diagnosed. It does not lead to mortality.
Right.
And definitely rotavirus vaccine are important tool to bring down the number 2 cause of under 5
Severe
mortality.
dehydration. Okay, so now rapid fire, we are going to go from panelists 1, 2, 3 in rotation. So quickly as the questions go, one of you will answer only in one line.
Faster.
What is the maximum upper age of administration of the first dose?
16 weeks.
Sir, correction.
14 weeks and 5 days. 6
14
days.
weeks, 6 days. 14
Yeah.
weeks, 6 days is the maximum upper age. RV vaccines should not be initiated after what age in infants? Praveen sir.
after 14 weeks and 6 days, we should not initiate.
15 weeks and 0 days. So
That
according
is
to our age.
for-
Yeah.
See, 15 weeks are completed. I
Yes,
will
sir.
prefer
Yes,
not
sir.
to, let
Yes,
us not
given,
split
sir,
the
sorry.
hair on this.
Yes, sir. The jury says okay. What is the maximum upper age for the final dose of the series? Sir,
32 weeks except the,
Exception?
the serum vaccine which as per the government schedule can be used up to the age of 1 year.
1 year.
At the product
As per
insert,
the
And the
product.
product insert.
But
Dr.
IAP says
Gokhale.
no.
Dr. Gokhale, why is the discrepancy of maximum upper age of getting the first dose of RV vaccine kept as 1 year as per the UIP? Different.
It's more of an operational deadline that they have kept. It is due to operational reasons rather than any other reason. That is what I understand.
So
No,
anything you
they
wanna
have, there are mathematical models where they have calculated that the number of rotavirus deaths prevented by extending the spectrum up to 1 year is 154 times more than the death occurring due to intussusception risk.
Right.
So considering this, in a public health program, the government sees the cost versus benefit, and that's why government has recommended up to 1 year, but on an individual case in private practice, I would prefer to stick to IAP guidelines of 32
8
weeks.
months, sure. So Vijay Irle, sir, what is
15
effect-
weeks and 32 weeks.
Absolutely, sir. Vijay Yevle sir, what if a child spits out immediately or within 30 minutes of administration?
Don't do anything. Call him for the next dose.
Dr. Gokhale, interchangeability in between brands.
It is completely allowed.
It is completely allowed provided there is
By
no
default,
other,
not
we
by
don't know,
choice. Not by choice.
In case of a missed dose, sir, repeat or continue the schedule?
No need to repeat. Continue
The schedule with all other vaccines, the same principle. Can OPV and Rota be given at
Yes.
the same time? Can the mother give breastfeeding immediately after the vaccine?
Yes.
Recommendations to give RV vaccine after a documented RV infection in a neonatal period.
I will give it because the very basic Mexican studies, if you see, when the RV1 was introduced, they found that with the number of infections, the efficacy increases of the rotavirus. And therefore, I will give, because this child has got only one infection, so I
Agree,
will
sir.
prefer
So
to
we
give.
will repeat. Dr. Yevle, in 2 lines, a word about Rotavac 5D.
Rotavirus 5D. See, the first Rotavac vaccine which was licensed and came to market had to be used with a lot of buffer, and it required stringent storage condition and -20. So they moved on to Rotavac C, which could be stored at 2 to 8 degrees centigrade. And then now they have come out with Rotavac 5D, wherein the volume is very little, 0.5 ml. It can be stored at 2 to 8 degrees centigrade. And this is the product which is available, which is in use in practice.
Dr. Praveen Gokhale, any absolute contraindications for giving rotavirus vaccine?
Yeah, known cases of immunodeficiency, especially SCID,
Scale.
and known uncorrected intestinal anomalies, there you should try to avoid the rotavirus vaccine.
Also, previous
Also past
history of
history of
interception.
interception, and
Previous history of
also,
interception.
also in the neonatal NICU, we don't use it.
Right, because it's
Because
an
of the
so we
spread to
give
the
it
other kids.
Once the NICU is ready for discharge, the graduate. So, Dr. Praveen, how does RV1, in spite of being monovalent, give protection for other RV strains, and that too just with 2 doses? So, partly we have discussed the first part. Why only with 2 doses?
Because they have done the studies with 2 doses and also with 3 doses, and compared, the efficacy was comparable.
Absolutely.
There are
So-
epitopes present on the outside surface. That is where the antibodies are produced against them. So I think that that is the reason why it gives cross protection.
Sure. Interesting fact for pet lovers here, dogs are the potential sources of human viral pathogens, and RV is the commonest cause of acute gastroenteritis in puppies, kittens, pigeons, and the other avian species.
So
So
start
moving on to the third vaccine,
Should
MMR.
start giving them rotavirus vaccine?
We'll find out, sir. Dr. Kasi sir will say if that is possible. Okay, so MMR. Next talk, next. Vaccine CME with a major difference. Okay, Dr. Praveen Mehta sir, why a deviation of the government schedule MR vaccine versus IAP schedule MMR vaccine?
This, I think, sooner or later will be corrected, but I will tell you the reason why the government, because government says that there is no data on mumps morbidity and mortality, and that's why the NTAGI has recommended to use MR, and as per government's view, the MR vaccine is cheaper than MMR. Adding mumps components becomes costly, although we all know that the MMR is one of the cheapest vaccine available.
Absolutely.
And now, since after the recent cases of lot of cases of mumps, lot of publications have gone to the government, including one from our friend Vijay Yevle from New Bombay, that what are the mortalities which are happening and what are the complications happening with mumps. So one day it will come under government schedule also.
So as it was not realized as a major disability problem, it wasn't included for the cost factor for sure. But as we all know that we've seen a lot of mumps cases in the last couple of years, and with mumps, aseptic meningitis, encephalitis, orchitis, and pancreatitis, soon it is going to be a part of the national immunization schedule also. So Adil has taken his first dose MMR immediately after his first year birthday and needs to travel back to Saudi. When earliest can he take his second dose? Dr. Praveen Gokhale.
Usually a gap of 8 weeks safe is safe between 2 live viral vaccines. So he can take the second dose whenever he goes back to Saudi, if it is available there, or whenever he comes back.
No, sir.
CDC has recommended
He has to take it from here and go back. So minimum period that you can
4 weeks.
4 weeks. So minimum 4 weeks gap can be given. Within how much time should a reconstituted MMR vaccine be used, Dr. Gokhale?
It should be used immediately after reconstitution, but if for some reason it has to be kept, it can be refrigerated immediately and used up to 8 hours.
4 hours? Sir?
4 hours.
4 hours, sir. Yes, sir, one session, 4 hours. Dr. Vijay Evle, what is the catch-up vaccination schedule for older children?
So child who has not received any MMR, MR or mumps any vaccine in the past
Measles.
should get at least 2 vaccines, which can be given 4 weeks to 3 months apart. So ideally it will be 3 months apart, 2 doses.
Sure, sir. So Praveen Mehta, sir, what is the 0 dose of MMR?
Actually, to tell you frankly, I exactly don't know what is the 0 dose as far as MMR is concerned, but the WHO defines 0 dose as a child who has not taken any vaccine whatsoever at all, not MMR, but any
Any other
vaccine. That is called a 0 dose child.
In
I
relation
think
to
zero
MMR,
dose
Dr.
MMR
Yegle,
is
sir.
zero dose MMR is probably a child who has received MMR before the recommended age of 9 months. So sometimes in outbreak setting we give between 6 and 9 months.
So which-
that the child needs protection, but that dose is
Not
disregarded,
counted, not counted, disregarded.
And
So that exactly happened last year as we saw a lot of measles outbreak, and even children of 6 months of age in those pocket areas were given a MMR, but we know that there is going to be an interference in the seroconversion because of the circulating maternal antibodies. That is not counted, and the 9-month dose is counted as the first dose. MR, measles containing, sir, MR. So, any role of MMR for post-exposure prophylaxis? Dr. Praveen Gokhale?
Yeah, if it is given within 7 days of exposure, then it can have some role in prevention.
It's
should-
less than 7 days, sir, or is it within
it
7
should be
days?
given
Within
within 72 hours,
72
and that's
hours.
applicable for measles and mumps. Rubella, there is no recommendation of.
So, only for measles probably?
measles.
For mumps and
Even
rubella, they
mumps
say
also.
even
Measles
mumps.
and not for rubella.
Okay, sir. Minimum gap for administering MMR after a child has received a antibody containing blood product or IVIG.
See, it will depend upon the what kind of antibody containing product that you are using. If you are using washed RBCs, you can immediately give MMR. If you are using the whole blood, then don't give it for 6 months. And it also depends upon the dose. Suppose if you are using IVIG in low dose like replacement therapy to 300 to 400 milligram, then in that case it is 6 months. If you are using it for ITP, say higher dose, 1000 milligram, then 8 months. For Kawasaki, if you are giving 2 grams, then it is 11 months.
So the range is very wide and it's 3 to 11 months depending on exactly what sir said. It will depend on what you've taken. So yes or no, Dr. Praveen Gokhale, can it be given to children with cow's milk allergy?
Yeah, yes, it can be given, but under controlled conditions
With
if it's a
precaution.
known case, because there have been very few cases where such a type of reactions have occurred. So in a controlled condition, hospital setting with all equipment ready.
In a known case of egg allergy?
Yeah, see, again, the children having, it has to be taken with the information of parents, again in controlled conditions.
So
there have been
apparently-
recommendations to give
Yes,
it,
sir.
basically. I will give it.
So
I will give it.
Apparently egg allergy is no contraindication to give, even if there is a known case of
There
egg.
have been just a few cases, that's why it's like to inform the parents, keep everything ready, even for that remotest possibility. But that, you know, like there is no, the cow's milk protein and egg allergy, they have some kind of a cross relation. So if you have a known case, it is not a contraindication, you cannot give, but you have to inform
Under
the parents
precaution.
that there may be a possibility.
Dr. Praveen Mehta, sir, HIV infection?
HIV infection, we have to look at whether the child is symptomatic or asymptomatic. Asymptomatic, you give it.
Sure, sir.
And in symptomatic, you see, look at the CD4 count. If it is more than 15%, you can give it.
And people with thrombocytopenic purpura?
It is a precaution,
Right, sir.
but it's not a contraindication. You can give it.
Sure.
HIV
Vijay-
cases, generally there is a some criteria for the CD4 cells. If they are less than 200 absolute count, then you should not give the vaccine.
Live vaccine. Dr.
ITP has
Vijay
been
Yegle?
related with the MMR vaccine, but you know, again it has not been proven as
Proven,
such.
proven. Sir, why was MMRV withdrawn from the market quickly?
So the incidence of febrile seizure-like reactions were more common than MRV. The true reason for withdrawal was it was much costlier, and there was no business.
For the Indian market.
And uptake was very less.
See, there was some reason of febrile seizure
Yes, sir.
given.
Mike.
So when you want to use MMRV as a one vaccine in the same vial, your varicella dose has to be very high. And varicella vaccine generals are in short supply in the Western countries. That's the reason why MMRV was not a priority. But it is still available. Both the companies, MMRV is available internationally. It's not withdrawn. So it's not available because it's not the priority. And I think generally the first dose febrile conversions are more with MMRV than when given separately, and febrile conversions are very common in the first 2 years. So as such, for the first dose is a precaution to use a combination even when it's available. So when you are not using for the first dose and using separately, for the second dose to make someone spend almost 2 or 3 times more, I think it doesn't make sense. So for all practical purpose, even if it's available for a very few finicky parents who want only one injection, I would not use it.
Sure, sir. So measles virus can remain in airspace for 2 hours after contamination by an infected person. Animals do not get or spread this red measles, hard measles or 10-day measles. Moving on to hepatitis A, we'll have to be a little quick, so one-line answers. Dr. Praveen Gokhale, sir, live attenuated versus inactivated.
I can give either of the two.
Great. So what we get the message is both are equally effective. What is the upper age limit for administering pediatric doses of inactivated vaccines? The 2 brands which are available in the Indian market. Any upper age of administration of the pediatric dose?
18 years.
18 years for both, sir?
Both.
Okay. Is it same for both? Okay. What if the live attenuated vaccine dose is inadvertently given intramuscularly?
You don't need to repeat it because it's a live vaccine. Anywhere in the body you give, it's going to multiply on its own. Basic principle of immunology.
Dr. Vijay, sir, what is the catch-up vaccination schedule for both live attenuated and inactivated in older children?
A child who has not received hepatitis A vaccine and who has not had natural disease can be given 1 dose of live attenuated hepatitis vaccine or 2 doses of inactivated hepatitis A vaccine. Now, if the child is below 10 years, you can give it without doing any antibody titers. About 10 years, one may do a titer and give
One may do, but regarding the cost effectiveness and sir, the upper age, till what age would you recommend considering subclinical immunity in endemic countries? So would you put
See,
an upper age?
IAP guideline says that up to 10 years, by the age of 10 years, nearly 50% of the population is seroconverted, whether vaccinated or not vaccinated. So you consider up to 10 years. Beyond that, the IAP recommends that you do a antibody level, and if it is positive, don't give the vaccine.
And any special groups of patients will you recommend it strongly?
Strongly in the chronic liver disease, then the carriers of hepatitis B and C, and immunosuppressed patients, and finally, of course, the homosexuals who indulge in the anal sex, because basically it is oropharyngeal route by which it is transmitted.
Also for travelers to endemic countries, sir?
Travelers to endemic countries.
Drug abuse.
Especially children who come on vacations back to India, maybe you can tell them, because there will be future visits also.
Vijay Evle, sir, the post-exposure prophylaxis schedule for HIV. For whom, within what period, and in what age group?
Household close contacts within 2 weeks of exposure to a case of index case of hepatitis A, more pertinent to individuals who have chronic liver disease, who are immunocompromised, and it can be given, of course, in the age eligible window only.
And within how many days, sir?
14 days.
2 weeks. Any role of single dose schedule for inactivated vaccine? Globally, any studies or any trial?
There are 2 studies, one from Nicaragua, and where the follow-up was very short, up to 6 weeks only. And following 6 weeks, they found with single dose 100% efficacy, but the data is only up to 6 weeks. And there is another study from Argentina, where it was used in the national immunization program. And at the end of 6 years follow-up, which is available now, it says that there is not a single case of hepatitis A. But this is in the national immunization program. But there is a study comparing 2 doses versus 1 dose of live as well as inactivated, and which shows the much higher level with 2 doses. So in private practice, till we get more data, we will continue giving 2 dosage.
And so what is the median predicted age of protection by the vaccine? It's
45 to 50 years.
45 to 50 years. And why this a little different with this inactivated vaccine, sir?
Pardon?
Why is this so with this inactivated vaccine that even
Because
without
of
this dose?
anamnestic response, that is.
So the key messages are hepatitis A is indicated in all children above 12 months of age. Both live, attenuated and killed are equally effective. Vaccines generate long-lasting, possibly lifelong protection, and both live and killed can be used for post-exposure prophylaxis. Moving on to the last and the HPV-4. Does a 4-valent vaccine offer cross-protection from other important carcinogenic serotypes?
Very short-lived.
Very short-lived. Why is a 6-month interval recommended in between 2 doses of HPV vaccine? And what if the second dose is given earlier than 5 months recommended gap in between 2 doses? You can take up, sir.
Okay. 6 months interval because it's the time taken for germinal centers to have affinity maturation, for production of memory cells, and for class switch. So if you look at any vaccine, now they have done 0, 1 and 6 and compared it with 0 and 6, and they found out that the 0 and 6 works better, particularly for children who are below 14 years of age. The second dose is given earlier than 5 months, then in that case, recommended gap between the 2 doses is 6 months.
Last 2 doses.
So this I will not consider as a valid dose and give 1 more dose after 6 months.
How long is the vaccine-induced immunity established for with the quadrivalent or the nonavalent for that matter? We are looking at quadrivalent.
After completion of schedule, it gives quite a long-lasting immunity, and studies are still continuing in the primary group, which are showing that there is still no change in the protection rates.
We have data from 2 sites.
Future trial.
One is the Indian BASU study where there is efficacy, not immunity, efficacy, proven efficacy for 10 years, and this Costa Rica vaccine trial, which also has long-lasting efficacy.
So no boosters are required at the moment, right?
Currently, no.
Why is one brand
That too
of
with
the
single dose, and that too with single dose.
single dose, right? Why is one brand of the currently available quadrivalent vaccine approved for girls and boys and the other only for girls?
They were tried that way.
So basically only because of the
Right.
clinical trial data. And why is one brand licensed for use in females till 45 years as against the other with the same serotypes licensed only till 26 years?
Again, the recommendations have to be based on certain studies, and that is why it has been this way.
So we'll quickly take up this in one word. 13-year-old Sonakshi has received 2 doses of HPV-4 at 2 months interval. Does she need a 3rd dose and when? Which, sir?
Yes, with a gap of 6 months.
Sonam received her first dose of HPV-4 at 13 years, 11 months. How many doses should she get and at what interval?
She can receive 1 more dose after 6 months.
16-year-old Sri Devi has started her series with first dose of HPV-4 but wishes to continue with HPV-9. Your advice, sir?
Can be done.
What is the association in between HPV and POTS?
POTS is the postural orthostatic tachycardic syndrome, and which is, so there are some cases reported that following HPV vaccine, there were giddiness and the fall because of the fall in blood pressure and tachycardia. So the treatment is very simple, just make the adolescent girl lie down for 15 to 20 minutes. And that should, in most of the cases, solve the problem.
Sure, sir.
In a lighter which occurs otherwise also in adolescent girls.
Yeah, absolutely. So, Michael Douglas suffered from HPV infection. No HPV has been detected in any other host other than humans. So, food for thought. Thank you so much. Thank you, dear panel.
Thank you, Dr. Nehal, and all our respected panelists.
So again, a vaccine CME with difference. We have made these beautiful stickers, which children like to put on their folders, files, etc. Some of you would have received from GSK in past. So I specially asked them to make for all delegates. So please collect this from their stall. They will give a hamper which has these stickers. So they are really nice. I mean, children crying, you put them on their files, they feel very happy. Like they are all saying Bond Star, Champ, thumbs up, well done, etc. You know, so please make use of these stickers. Thank you.
So thank you, Dr. Nehal, and our esteemed panelists for that wonderful session, which had received an unrestricted scientific grant from Serum Institute of India. We come to our next topic, and it was bacterial meningitis that struck a 19-month-old Helen Keller. And although she overcame her blindness and deafness and provided inspiration to the world with her resilience, everyone's not so lucky. We are talking, yes, about a deadly, dreadful disease of meningitis, and unfortunately, it has a very, very high death rate. I now invite Dr. Vijay Yevle, our next expert, to tell us more, not just about the A, B, C, but also the W, Y, and the Z of this particular meningococcal meningitis vaccine in his talk, Mind the Meninges.
No, that's okay. Thank you. So mind the meninges. I'm going to talk about how does one protect the meninges or prevent the meninges from getting infected. So beyond neonatal period, the meningitis, acute bacterial meningitis in a child coming from the community is caused by only 3 bacteria: Streptococcus pneumoniae, Haemophilus B influenza, and Neisseria meningitidis. WHO has set a goal, and we are moving towards a world free of meningitis, wherein we wish to reduce the case of vaccine preventable meningitis by 50% and prevent deaths by 70%. Now, if you look at the vaccine preventable meningitis, you have Hib, pneumococcal, and Neisseria meningitis. We have Hib vaccine in the National Immunization Program. We also have pneumococcal vaccine. There is an excellent vaccine available to prevent even the meningococcal vaccine, that is meningococcal conjugate vaccine. And today I'm going to discuss this vaccine, and this is what we're going to look at, the epidemiology of meningococcal disease. Why do we need to prevent it? How do we prevent it? How good is this MCV, and what are the recommendations? Meningococcus has 12 serogroups. A, B, C are the commonest, which are infecting humans and have epidemic potential. There is no extra human reservoir. Incubation period is about 2 to 10 days, and it occurs in very young children, especially below the age of 2 years. And there is second peak which is seen at in adolescent age group. In fact, the nasopharyngeal carriage is highest in this adolescent age group, and this has implication when one decides to introduce this vaccine in the public health program, and even otherwise to protect an individual. And there have been cyclic trends, and we have witnessed epidemics occurring almost every 10 to 20 years in the past. I would straight away recite a case that I saw in my personal practice. 9-month-old boy came to us in shock, was resuscitated with IV fluids, was put on inotrope. The child had fever, irritability, and poor feeding for a few hours prior to coming to our hospital, and this child died within 6 hours of admission. We had managed to collect blood and performed a lumbar puncture. CSF was suggestive of acute bacterial meningitis. So what was it? Very devastating for parents. Child who was playful in the morning died in the evening. So this child died of septic shock with meningitis, rapidly progressed to death. Etiology, as I said, it could have been one of the 3. And we were trying to find out if there were any clues to a definitive diagnosis. He was a resident of Navi Mumbai, but there was no rash. So we tried to analyze this patient. There was a rapid progression to death. So we know that it is invasive meningococcal disease which progresses very rapidly. Initially the symptoms are flu-like, pretty non-specific, and in a matter of few hours rash appears, and then the child develops meningitis or meningococcemia and succumbs to the illness if not picked up in time and treated promptly. So the median time is about 13 to 14 hours from the onset of symptom to hospitalization, and most of the deaths occur within 24 hours. So probably this was Neisseria meningitis. And very next day our microbiologist called up saying that he had isolated the Neisseria both from blood and the CSF. We were wondering, but there was no rash in this child who came from Navi Mumbai having Neisseria meningitis. So if you look at this publication from Dr. Rashna Das Hazarika, and in her outbreak, the last outbreak which was investigated, about less than 25% of the patients had rash. So it's a myth that meningococcal meningitis or meningococcemia comes with rash. And then this child, as I said, was hailed from Navi Mumbai. Is meningococcal disease common in Mumbai and Navi Mumbai? So let us look at what evidence we have with respect to the epidemiology of this disease. The data that we have is from outbreaks. Very scanty data is available for the inter-epidemic or inter-outbreak period. Majority of the cases are in winter and spring. There is peak activity in low humidity, and poor living and crowding it predisposes a child to contract meningococcal infection. So the inter-epidemic data basically comes from the disease surveillance, whatever disease surveillance that we have in our country, the Integrated Disease Surveillance Project or the Central Bureau of Health and Intelligence and NCDC. Epidemic, of course, is investigated, and we have the community-based data, laboratory-based data. If you talk of outbreaks, there have been outbreaks occurring at regular intervals, a decade or two. There are unusual increase in cases. Most of the outbreaks have been concentrated in the northeastern part of our country. Majority of them have been primarily by serogroup A, and these outbreaks are more known in temperate regions. So like your African meningitic belt, probably there is a sort of a belt which extends from the western part of the country to the northeastern part. If you look at the inter-epidemic data, whatever data is available in the National Health Profile of India, there have been cases as shown in this slide reported of meningitis. But this data needs to be analyzed a little carefully, because the reporting is done as probable meningitis or lab confirmed meningitis, and there is no detailed analysis of this data, whether they were lab confirmed or no. But yes, it suffices to say that meningitis does exist, and it is seen across the country and in different age groups. This is a beautiful systematic review which is published recently, and it says that about 3.2 of acute meningitis is caused by Neisseria. In endemic setting, the prevalence is about 0.76. Now, if you look at WHO recommendation, countries advised to undertake vaccination if the rate is more than 10 per 100,000. So maybe 0.76 would fall into that thing. Epidemic setting, definitely you have higher prevalence, and it occurs across all age groups. But most of the disease is concentrated in young. How common in India? We have already talked about it. But what is probably detected is only the tip of the iceberg, because of suboptimal surveillance that we have in our country. Antibiotics are used. Fortunately, Neisseria continues to be susceptible, and by the time we do a lumbar tab, the CSF or blood is negative for culture. And then the laboratory are not available so rampantly everywhere. And molecular techniques which have better yield are not again available, and at times cost prohibitive. So diagnosis, we rely on cultures, and if you look at this series published by Dr. Sushil Kabra from Delhi, in 852 cases, 720 did not grow anything. So as such, culture yield is not very great, especially it's almost impossible to get an antibiotic naive patient. There are other methods. It's better to use multi-pronged approach, do antigen tests, molecular tests, and the blood and the CSF culture. With antibiotic use, the culture yield definitely goes down, as shown on this slide. Now, there are many publications which talk about the disease being mainly present in very young age. You have publications from US, from the European countries. Then there are so many publications of the northeastern part of our country, which again, I would summarize saying that the disease is concentrated in the very young, below 5 years and more so below 2 years of age. And then the second peak is in adolescent age group, because that's the age where the carriage occurs. So this is a basic difference between the Hib, pneumococcus and the Neisseria, where the carriage age or the incidence or peak of carriage is different from the occurrence of disease. Young children are infected and affected with this disease, and so also the adolescent. The carriage is primarily seen in the adolescent age group, and this again has implication in the vaccination schedule. So invasive meningococcal diseases with high mortality, 15% of them would, when diagnosed early, even with adequate treatment, would die, and 50% of them would succumb if they're not picked up early. And we know that a lot of sequelae it leaves behind, cognitive disorders, hearing loss, seizures, anxiety, motor defects, renal failure, so on and so forth. And these sequelae are more common in infants and children as compared to adults. They are more common, they are more severe, and they are more in numbers, different sequelae in infants and children as compared to adolescents. So meningococcal disease is something which is easily misdiagnosed because of its presentation with overlapping features with other common illnesses to begin with. However, the disease progresses extremely rapidly and is associated with extremely high morbidity and mortality. So it's better to prevent it. Now, how do we prevent Neisseria infection? Chemoprophylaxis is one which is used in close contact of an index case, best when used within 24 to 48 hours. People in the same household, roommates, or anyone who is, especially healthcare workers who come in contact with the patient's oral secretions. But that's not the way to prevent meningitis when it occurs in outbreak. And even otherwise, the best way to prevent such a deadly disease is using a vaccine. Now, there are two vaccines which are available, the polysaccharide and conjugate. We would talk about conjugate vaccine. As a thumb rule, remember, whenever a conjugate vaccine is available, it is better to use conjugate vaccine and replace the polysaccharide vaccine, which lacks the herd effect and cannot be used in very young children below the age of 2 years. We have two quadrivalent conjugate vaccine available in our country. One is conjugate with diphtheria toxoid conjugating protein, the other with CRM. The one with DT is licensed for use from 9 months onwards, and whereas the one with CRM that is marketed by GSK is used from the age 2 years and above. Well, each vaccine, before it is licensed and used in the country, it requires country-specific immunogenicity data and studies. So the quadrivalent vaccine, which is conjugated with CRM, has undergone immunogenicity study, and it has demonstrated non-inferiority when compared to the DT conjugate vaccine, which was the comparator used in the immunogenicity study. So it has demonstrated non-inferiority to all serogroup A, C, W, and Y. And in the studies which were done outside, in fact, the titers were superior for the C, W, and Y. Now, how long do the antibodies last? Because meningococcal disease is disease with extremely short incubation period time. You need to have readily available antibodies in circulation. With other conjugate vaccine, even though there is memory response, the immune system takes some time to mount that anamnestic response. So one needs to, it's a play between the incubation period and the time taken for the anamnestic response. So with Neisseria, the incubation period is extremely short, shorter than the time taken for the anamnestic response. So following use of the conjugate meningococcal vaccine, there is waning of antibody titers, especially in the first year, and thereafter these titers remain more or less stable, and the waning is more with antibodies against serogroup A, and it is more pronounced in infants and toddlers. If you give it at higher age, the antibodies will last a little longer. However, this does not really impact protection in the vaccine. A single booster dose given after 3 to 5 years of interval elicits a robust immune response. Again, these factors are taken into consideration when you devise a schedule or design a schedule for a meningococcal conjugate vaccine. What about efficacy? We talked about immunogenicity. Efficacy data is available only from the polysaccharide vaccines. Given the reduction in the disease that occurred in the Western world, the subsequent vaccines were never tried for efficacy, but the immunogenicity is taken as surrogate, and all the vaccines have been. But in the US Army recruits, the C and A vaccines have demonstrated excellent efficacy. Now, this is a data talking about the effectiveness of a single dose of the quadrivalent meningococcal conjugate vaccine with CRM conjugating protein, Korean Armed Forces. And it post-vaccination, it helped to reduce the disease by almost 88%. So that effective is the vaccine. So it's an excellent vaccine. So let's talk about MC vaccination in children below 2 years of age. In the Western world, a lot of countries are using this vaccine in their public health program. And in Netherlands, for example, after putting this vaccine in NIP, they could bring down the disease burden from 2.87 per 100,000 to almost 0.2, a substantial reduction. Similarly, in Brazil also, most of the disease which occurred in young age, below the age of 2 years, there has been more than 90% reduction in the disease just by using this vaccine in their national program. So now, having talked about this vaccine, let's look at the global recommendations and what does IAP say about it. So different countries have different vaccination schedule. Currently, there is no agreed consensus on a single optimal schedule. And with the epidemiology and when the vaccine is put to use, the epidemiology changes, the disease burden comes down, and each country has tweaked its immunization schedule. But one thing is certain, that direct protection is desirable in the young age group where the disease is concentrated, and one must aim at decreasing the carriage so that with the conjugate vaccine, let's take advantage of the herd effect. And if you reduce the carriage, obviously the young infants and toddlers would get benefit out of it by halting the transmission. So this I have already talked about, that you need to have readily available antibodies above an optimal level which is required for protection, and that is why you need multiple doses. And we already said that younger the child at the age of, younger the age at the time of receiving the vaccine, faster is the waning. So there is again ample data talking about the antibody kinetics of anti-Neisseria antibodies. When you use 2-3 doses in the first year or a toddler dose, there is significant decline in the antibody. And this is what is looked at, and the country has made its schedule. Say for example, in the United Kingdom, they had meningococcal C disease. They started using conjugate vaccine, the monovalent vaccine, in 1999. To begin with, they had 3 primary, 2, 3 months and 4 months. And they introduced a campaign mode for catch-up up to 18 years. They could bring down the disease burden. They dropped the 3rd dose in the primary schedule in 2006, and they added a booster. This is the time when they added a booster of a Hib vaccine. And in 2013, they realized that even if you give single dose in the first year of life, the impact would be similar. So they dropped the 4-month dose and they switched over to 1 primary and 1 toddler dose. And because of an excellent herd effect, the disease went down so much. Now they practice only 1 single adolescent dose. So the point that I am trying to make is meningococcal vaccine is disease is seen in young age, but the carriage is at an adolescent age. If you achieve substantial reduction and protection of adolescent age, it has excellent herd effect that spills over, and the young infants can be protected. Most of the countries which are using meningococcal vaccine, they have a dose in the 2nd year of life. What does IAP say? it is a vaccine to be used in outbreak setting, in high-risk conditions, especially children with terminal component deficiency, children with hypo or asplenia, both functional and anatomic, HIV-infected children, laboratory personnel who are at a risk of contracting this disease because of sheer close contact as an adjunct to chemoprophylaxis. And then international travelers, students going abroad, Hajj pilgrimage and African meningitic belt where you are. But if you look at the scenario today, the risk factors are pretty rampant and prevalent in our country. There is frequent mass gathering, religious purpose or festivals. There are so many things, and we just need a reason to gather. And overcrowding in urban towns, younger population, student population. There is a lot of adolescents who are staying in hostels and dormitory kind of setting, and international travel, the kind of travel that we take. And of course, we have army personnel. Even today, they are protected against meningitis by using this vaccine. So, I believe that there are factors. The risk is not as less as it is perceived to be. It is very well said by Dr. Jacob John once, that evidence of absence should not be equated with absence of evidence. So, there is a good vaccine which is available. One should not, the onus is on us to make the parents aware of the availability of vaccine. Don't be judgmental and let the parent make a choice. You don't decide for the parent, but it's our duty, and especially with the goal to move towards meningitis-free world. This is one vaccine which was the missing link. We have pneumococcal and Hib. Now we have a very good vaccine, and I showed you the data. But as on today, we have competing priorities, and this is not the vaccine which is put in the National Immunization Program. And during outbreak, you calculate the attack rate, and this is the formula, and then you decide. What is the schedule that is recommended? The DT conjugate vaccine can be used from 9 months. So, you give 2 doses, first in the first year of life and the second 3 to 6 months after the first dose. And you have ample opportunity when children come for other vaccines, and this vaccine can be co-administered with other vaccines which are used in this age group. The MCV conjugate vaccine, which is CRM conjugated, is licensed for use only above the age of 2 years, can be used up to 55 years of age. In US, the recommendation to use 1 dose in adolescents, and that can be practiced here as well. What is the rationale for vaccinating 9 and 12 months of age? Is it addresses the need of vaccinating protecting these young children. There is better percentage of titers as compared to 3 doses given in infancy we saw from the UK schedule. It avoids issue associated with crowded vaccine schedule when practiced at 2, 4, 6 months. And of course, none of these vaccines is licensed for use in our country at this young age. And there is high uptake rate when you use this vaccine at a later age. So to conclude, friends, globally the incidence of IMD is high under 2 years of age with high morbidity and mortality. 21 out of 24 countries are using vaccine in their national program and are giving a toddler dose between 12 and 24 months. MCVs are immunogenic and safe. You can use either of them, and 2-dose schedule in Indian children between 9 months through 23 months. But the MCV CRM is licensed for use only above the age of 2 years. MCVs can be given concomitantly with other routine vaccines like MMR, varicella, pneumococcal vaccine, hepatitis A, and the combination vaccine which is used as booster dose in that age group. This session was supported by academic grant from GSK, and this is their product which is available in our Indian market. Thank you.
So friends, one more vaccine CME with difference. The faculty are given their photograph of receiving the memento right on the spot. So this is the first one to be Dr. Kasi. Okay. More important, as you know, all of us have some schemes on vaccine when we purchase for our clinic. For today only, there are special schemes both by Bharat Biotech and by the Novo Medical Sciences. So if anyone wants to interested in booking their vaccines of these two companies, please visit the stall and give your name, and you can avail of the extra benefit over and above what you get in your clinic day to day.
I think those were very attractive schemes announced by Nitin Shah sir. And now we move on to snippets. So these snippets, these are short focused talks. This was introduced last year by Nitin Shah sir, and they were a great hit. So this time also we have included it. This time it is for 15 minutes. And we have a very interesting topic. When in doubt, look at the mouth. We all know Ma Yashoda Maiya has taught us, when she looked inside Krishna Bhagwan's mouth, she could see the entire Brahman, isn't it? So as doctors, we must never forget to look at inside the mouth. And for this, I would like to invite Dr. Rajesh Kasla sir. He is the President-elect 2025. It's HFMD vaccine.
Thank you, Dr. Nitin sir, for inviting me for this particular topic. When in doubt, look at the mouth. I'm going to talk about hand-foot-mouth disease vaccine. As we all know, the last decade, there has been a tremendous increase in the number of cases of hand-foot-mouth disease. And it is so common that the topic which is mentioned as when in doubt, look at the mouth. Here I would suggest that don't keep any doubt. Whenever the patient of fever comes in the OPD, look at the mouth. You will definitely find some ulcers in the mouth to pick up this hand-foot-mouth disease. So, there are a lot of epidemiological events that has happened over the period of years. For all practical purposes, we have felt that hand-foot-mouth disease is a very benign condition. Child walks in with a history of fever, there is a rash, some herpes lesions. That's it, and most of the time, the children recover in a matter of 5 to 7 days. But looking at the literature, what happened was, from last 50 to 60 years, this particular hand-foot-mouth disease, which is caused by enteroviruses, has been found to cause some fatal neurological and cardiopulmonary complications. So enterovirus has been there for years together, though causing minimal morbidities, but there have been cases that have been reported causing a lot of fatal neurological complications, and after that, these complications also have been later on found to have long-term neurological sequelae. So, as we all know, commonly what has been seen in private practice or rather in day-to-day practice, that the lesions are mild. Almost 15% of them are asymptomatic. Around 85% of children will come with mild disease like fever. But there is around 1 to 1.5% of children who will have significant central nervous system involvement and even cardiopulmonary involvement. So, when we are talking about this involvement, which is around 1.1 to 1.5%, though we are not seeing very commonly in India, but yes, these enteroviruses are been documented abroad to cause these complications. The reason being that there are almost 100 enteroviruses which are causing different type of morbidity, but in India especially we are seeing Coxsackie virus which is causing these problems. So Coxsackie virus doesn't cause much of neurological complications, but yes, it is known. The damage due to this enterovirus can be a direct cytopathic effect, or it could be an immune-mediated effect too. So as you can see from this, that it is a multi-system involvement. Though the incidence of this multi-system involvement can be just 1 to 1.5%, and even mortalities has been reported with enterovirus infections. There are some 100 enteroviruses which are causing the problems of, myriads of presentations and myriads of morbidities. But the commonly incremented serotypes for hand, foot, mouth disease is enterovirus 71 and Coxsackie viruses. In enterovirus, again, there are genogroups from A to H, and out of this A to H, B and C are the common genotypes which are seen in Eastern Asia. And again, they are subsequently serotyped into C1 to C5 and B1 to B5. Now, I know this slide looks a bit boring, but what I want to emphasize here is that C1 and C2 are very common in Europe. C4 is the one which is very common and in China. But in India, we will see B1, B2, and even B5. But in India, what we are seeing is the enterovirus which is responsible for hand, foot, mouth disease is mostly Coxsackie virus. And in Coxsackie virus also, there are certain serotypes, the common being CVA6, CVA16, and 10. So this is the enterovirus gang which is causing morbidities worldwide. In other parts of the world, it is this enterovirus 71 which is causing this acute febrile illness, oropharyngeal ulcers, vesicular rashes, and EV71 is the one which is commonly involved in causing neurocardiopulmonary complications, while CVA6, which is more common in our Indian setup, here we will find a lot of atypical herpes-like lesions. You will see a lot of nail changes that are happening. So more or less it is causing more of morbidity, but EV71 is the one which we should get, which is worrisome. So this is a worldwide distribution of different, the common 4 serotypes which are responsible for the morbidity. If you see the top A1, that is the enterovirus 71, which is showing, as far as India is concerned, you can see India is represented in all sorts of, all the 4 serotypes are prominently seen, whether it is enterovirus 71 or all the 3 Coxsackie viruses. So that means there is prevalence of this particular, all the 4 serotypes in our country. As I already explained that most of the cases will be mild, but 1 to 1.5% are known to have severe and critical complications. So we will have to be on the lookout for this 1% children who may progress and cause problems. So these are certain risk factors. The children who are having hand, foot, mouth disease who present to us with high fever, they have central nervous system involvement, if they have abnormal respiratory rate or cardiopulmonary dysfunction, they have increased white blood cell count, if there is increased blood glucose and lactate, this has been documented as the risk factors for severe HFMD. So what is in store for HFMD with us? What can we do? The pharmacological intervention that has been used are antivirals. Though antivirals are not validated as a treatment for HFMD, interferons and ribavirin has been used, and ultimately we have to provide them the cardiovascular support if they have those complications. We have to manage the intracranial pressure control, and if required, they are put on ventilators. Prevention, yes, isolation of the patient, that's what we advise in our day-to-day practice. We provide them good oral care and skin care, but vaccines are the most effective way to prevent the enteroviral infections. So let us see. Now, I understand this slide may look a bit boring, but I will try to explain this because this forms the basis, this forms the basis of the vaccine manufacture. So there is this particular diagram is for enterovirus 71 genome, where there is this viral genomic RNA which is responsible for coding of a large polypeptide protein. And during this viral replication, this polypeptide is broken by these proteolytic enzymes into P1, P2 and P3 protein. Just that we remember these are the 3 proteins, out of which the P1 is the most important one. This P1 is further broken down into 4 viral capsid proteins called as VP1, VP2, VP3 and VP4. And of this, the VP1 is the most important one because that carries the neutralizing antibodies epitopes, and it helps for the serotyping as well as recombinant vaccine production. So, what about the vaccines? What is there for the vaccines? What has been going on in the whole world about production of this vaccine? So, there has been research about monovalent and polyvalent vaccine. The strategy here is that we provide the structural viral proteins, either whole cell or part of the viral proteins, to the host, where we expect a good immunogenicity of the host and production of viral neutralizing antibodies. So, there can be two types of vaccine, monovalent and polyvalent. As you saw, that there are multiple serotypes which are responsible for causing hand, foot, mouth disease. So, the monovalent vaccines which are there, it can be inactivated whole cell vaccine. So, here what happens is, when you are giving a whole cell vaccine, I mean whole cell antigen, the neutralizing antibodies that are produced are quite good, and the immunogenicity of these vaccines will be good. And subsequently, we can also have vaccines which are produced from peptides and protein vaccines and even recombinant subunit vaccines. Same thing, similar can be done for the polyvalent vaccines too. So, currently, this whole cell monovalent vaccine are available in China and Thailand, and this is purely for enterovirus 71 group, and this is manufactured from the C4 genotype strain. So, there are 3 vaccines which are licensed and available in China, that is Sinovac, Vigo, and one which is produced by the Chinese Academy of Medical Sciences. And if you look at the efficacy, in the first year the efficacy is almost 94%, and even in the second year the efficacy is 95%. Vigo has 90 and 100, and so overall the efficacy of these vaccinations are quite good. The efficacy against dangerous or life-threatening type of HFMD is almost 100% with this vaccine, and almost 85 to 90% against mild diseases. This vaccine is given between 6 months to 5 years of age. The primary immunization is 2 doses intramuscular at the interval of 1 month. The possible side effects of this vaccine documented are very common: fever, pain, swelling, and few systemic side effects, but nothing significant to, quite a reasonably safe vaccine. The vaccines which are not available, especially for us, because our country has more of Coxsackie virus infections. So, none of the monovalent vaccines, though there are animal models on which this has been researched. The vaccines are produced, but somehow there is this monovalent vaccine. The problem is that it doesn't have any cross genotype protection, and the neutralizing antibodies that are produced are not very long lasting. So, what we require is, we require vaccines for CV, A6, CV10 right now, because these are the prevalent serotypes in India. So, the effective approach for this particular hand, foot, mouth disease vaccines would be that we should have polyvalent vaccine. So, how is it possible? It is possible if we combine all the effective monovalent vaccine and produce a polyvalent vaccine. So, there are vaccines which have been produced, like they are bivalent, trivalent, quadrivalent vaccines. So, these quadrivalent vaccines, of course, they have been studied in animal models, and it has been found that even the quadrivalent vaccines, the immunogenicity, the neutralizing antibodies that are produced are quite effective in protection against hand, foot, mouth disease. Similarly, if those vaccines also can be produced by smaller peptide vaccines and other techniques like chimeric vaccines, and even in recombinant virus technology, this can be done, but the problem is that the immunogenicity of this particular vaccines will not be that good, it will not be that effective, and on the top of it, they require very strong adjuvants for creating these neutralizing antibodies. So, looking at the whole picture, the carry home message is, hand, foot, mouth disease, though it's a mild disease, but it has a potential to create cardiopulmonary complications, which we need to keep in mind. Hand, foot, mouth disease is a very contagious disease, so herd immunity is going to play a crucial role. Vaccination is the most effective way to control these infections, and presently we have only vaccine available against the enterovirus 71, which does not confer any cross protection against other serotypes like Coxsackie viruses. So till then, we stress upon other preventive measures of improving the surveillance and be mindful of those high risk factors which can cause to significant hand foot mouth disease complications. Thank you. Yes, ma'am.
Of China has become less, and now even their economy has gone down because they were saying that Sinovac for COVID was very good. Actually, it was not found good. So here Sinovac, which is made in China, what is the real report? Has it been tried in other countries?
Yes, Sinovac, in fact, WHO has recommended that Sinovac.
WHO recommended Sinovac. WHO was bought by China. Don't talk about WHO. WHO is useless. When I presented my paper in Paris about polio eradication, that time I had said I had done a trial on injectable polio vaccine versus oral polio vaccine, and I showed that if I can eradicate the polio in Dharavi, in Bombay slums, and bring zero paralysis, you can eradicate polio anywhere in the world. This happened in 1988-89. And that time I told WHO and I challenged them on the stage that you please close down your shop, give it to CNN, and they will eradicate polio. After that, Rotary took up the function, and then this is how the polio was eradicated here. So,
Okay. Yeah.
For those of you who don't know, Madam is Dr. Renu Patel. She was the pediatric head at JJ Hospital. She with Dr. Meenakshi Mehta did this wonderful trial in the ICDS blocks in Dharavi, showed one by one how if you give IPV, there is no case of polio vis-a-vis OPV which led to polio. There are two things that happened. I hope, please don't record this. If you can stop this, excuse me, stop just for 5 seconds. Yeah. So the result of the study was that Dr. Renu Patel was shifted out of Maharashtra to interior part of this one, and Dr. Meenakshi Mehta was given a show cause notice as to why she should not be rusticated. So that's how people who pioneered always suffered. But thank you, madam, for being here. I mean, I'm really surprised to see you here today. Thank you, thank you.
Thank you, ma'am, and thank you.
You can start the recording again.
Thank you, madam, for your inputs. Thank you, Dr. Kasla, for a wonderful talk. Now, as we all know that when we look at Dr. Nitin Shah's personality and his enthusiasm to learn and share, we can surely say that for him, age is just a number. And no one plays the number game of vaccine strains as well as him. And knowing the kind of social media person that he is, I can actually visualize Madhuri Dixit on stage singing 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, and sir comes and says, "Ruk re, 14 bhi hai." So, and with the elections in India that's going on, I'm sure over a period of time, Dr. Nitin Shah will say, "Ab ki baar 400 par." So, coming to it, is this number game in PCV strains actually a math or a myth? Let us know it from Dr. Nitin Shah.
Thank you for your kind words. Extremely happy to speak in front of Dr. Renu Patel. She was like the pioneer, as I said. And she stopped at 13, and then I reminded her 14. But I must tell you, it's going to go to 20. There are 215 which are in pipeline. There's a Chinese 13-valent which is in pipeline. There's a 20-valent from Pfizer which is in pipeline. There's a 23-valent from Biological E which is in pipeline. And this is an endless game. So what we need to know is what is existing, is it how good or bad as far as your practice is concerned? Because as I have been always saying, the next 2 decades of vaccines in the world are going to be Indian vaccine manufacturers. And that's why when Indian manufacturer makes a vaccine, the international agencies start trembling and having trouble. So I'm going to speak only on this 14-valent vaccine because we have heard enough number of time on PCV10 from Serum, PCV13 from Pfizer, and so on and so forth. So as I always do my disclosure that I have worked for almost every vaccine manufacturer in this country. All right, so we had this PCV7 which came first. Excellent vaccine, but for US specific market because it covered 90% of the serotypes seen in children there. For WHO to make it a global vaccine, it had to add more serotypes which are prevalent in other parts of the world. So that's how GSK made 10-valent vaccine, our Serum made 10-valent vaccine, and Pfizer made 13-valent vaccine. Now this remaining 6 serotype in Pfizer vaccine, or the remaining 5 serotype in the PCV10 of Serum, are the ones which are important from developing countries' point of view. So type 1, type 5, 7F are extremely important. Now 6 and 19A, when PCV7 was made, it was believed that 6B will cross-protect 6A, so they did not include, and then 19F will cross-protect 19A, so they did not include. Post use of PCV7 in USA from 2000, in the next 4 years, they saw that 6A disappeared. So there was almost near 100% cross protection by 6B versus 6A, but not 6C, which was an emerging serotype. So the next vaccine included 6A, but more important, 19F did not cross protect 19A at all. In fact, 19A went up from 2 per 100,000 to 8 per 100,000. So a very high absolute increase and a relative increase in the 19A disease. So the newer generation vaccine thereafter all included 19A in the vaccine. And now we have this biological ease new vaccine which has dropped 6B because there is cross protection with 6A, and for logistic reasons they could not make a vaccine which is similar to the existing vaccine, and added 22F and 33F, which are the serotype which are there in MSD's 15-valent vaccine, because they are the remaining. So they are not like emerging serotype. It's not that their serotype diseases increase, but of the remaining disease burden after using vaccine, what remains 22F, 33F are the important serotypes. So they included these 2 serotypes and made this indigenous 14th-valent vaccine. So why 19A is retained in PCV14? So this is a paper which looked at the non-vaccine serotype after using GSK's 10-valent vaccine, which does not have 19A but has 19F, and you can see number 1 serotype which remains in any of these countries where PCV10 of GSK was used was 19A. So there was absolutely no cross protection between 19F and 19A. And why is it that? Because if you see, the IgG looks very good between 19F and 19A. In fact, 85% of subjects who received PCV7 actually had an anti-19A IgG. But when those IgG were tested for its capability to kill the 19A in vitro by what is known as OPA, or the opsonophagocytic assay, there was 0 killing. So it was only a chemical protein without any effectiveness. And you can see here, if you look at the non-19A containing vaccine, which are the PCV7 and GSK's PCV10, the titers are 4 and 8 compared to a 19A containing vaccine like say PCV13, the titers are 440 or 60-fold higher. So that's the reason why 19A works when it's there in the vaccine. And it is also reflecting on the real world time data. So the ones on the top are blue countries using PCV13, which has 19A. The one in the bottom in the red are the ones which are using PCV10 of GSK, which does not have 19A. And you can see here in all these countries, the 19A disappears after use of PCV13. Otherwise, it went up. So you can see here went up here, it went up here, and then went down. Whereas if you look at the Chile, New Zealand, and Finland, you can see the disease just kept on increasing till the time New Zealand switched to 13-valent vaccine. So you can see Chile and Finland, which use only PCV10, the 19A went up very drastically. And not only in children who are directly benefiting, but as a part of herd effect. As you know, after use of PCV7, for one vaccinated child, 2 children were benefited by indirect herd effect without vaccination. So you can see without using the vaccine in above 5 years, after introduction of PCV13, 19A just disappeared from the community, whereas in all these 3 countries using PCV10, then 19A went up. So you need 19A in your vaccine, and that's why WHO position paper says very clearly that if you have a 6C, and we'll come to that a little later, or 19A, you should use vaccine containing these 2 serotypes. And now we have not 1 but 2 vaccines besides Pfizer PCV13, which has 19A, and that is PCV10 of Serum and the PCV14 from the biological E, which is the recent addition in the in our day-to-day practice. Now why 22F and 33F? So as on today, they are not very major serotypes seen in India, and you have 4 different data sets which looked at the serotype distribution of IPD in children, and you can see overall around 1 to 2% of IPD is caused by 22F and 33F, and 22F at least is also seen in the nasopharyngeal carriage in children, but it is a futuristic serotypes. So what do you mean by that? Again, you look at the paper, same paper where countries using GSK's PCV10, and you can see beside 19A, the remaining serotypes are 22F and 33F in most of the studies. And not only that, but now you look at the paper where countries using PCV13, and there are several countries using PCV13 as we know. If you look at the remaining serotype, then again you see 22F and 33F stand out. So these are the two serotypes which are going to be for future once we use vaccine in our national program. And we are using now PCV in our national program for last so many years now, and a very effective coverage. So this is the same thing which can happen in our country too in the coming years. So this is a meta-analysis that if you use either a PCV7 or a PCV13 or a PCV10, then 22F and 33F together are around 7% of the serotypes seen. As you can see here, 3.5 is 22F and 3.4 is 33F. So from that point of view, if you have a serotype in the vaccine today, even for tomorrow, it will have a better impact than a vaccine which does not have. And that's why the rat race of including more and more serotype is between the companies existing since the last 10 years. These are important serotypes because they lead to meningitis, they are carried as I showed, they can lead to severe disease and so on and so forth. Now, it's good to have a vaccine with some serotype, etc., but it should show also good immunogenicity and safety, if not efficacy. And why these new vaccines do not undergo efficacy trial is simply because number one, they are very laborious, number two, very expensive, number three, there is no ethical committee which will give permission to use a placebo because the vaccines are existing in the world. So it is impossible to do this type of efficacy trial, and that's why WHO says that you need not do efficacy trial, you can license a new vaccine based on a immunological study showing non-inferiority with an existing vaccine for which efficacy is available in studies. So you do immunobridging. So the predecessor has done an efficacy trial, I show my vaccine is as good as my predecessor, I expect my vaccine to be as effective when it's used in the day-to-day practice. So that is the way the licensing is done by the WHO's criteria of using IgG 0.35 microgram per ml of antibody with a new PCV which are being licensed. So this vaccine underwent a, see nowadays you see in past 20 years, 30 years it will take for a vaccine to come from bench to bedside. Whereas today you see this vaccine phase 1 adult trial 2017, 2022 is made available for commercial use. COVID, within 1.5 years of the COVID consortium putting the entire genome, the vaccines were made and used, and we have used 200 crore doses of vaccine. I think nowhere in the world has anyone been able to give this type of massive vaccination as what happened in India. So while India is shining, is going to shine, it has definitely shown a pathway forward to the world that what can be done by Indian manufacturers and what can be done by the public health infrastructure in India to reach out this life-saving vaccine in no time in the world. In fact, based on the COVID experience, the government wanted to include all the childhood vaccination also in a COVID type of app. Now the work is going on. It's a mammoth task because COVID vaccine was used only through public health, whereas the other vaccines are used also in private markets. So to make everything to go through one app is going to be difficult, but I am sure it will happen in the next 5 to 10 years. So this pivotal phase 3 trial which leads to licensing was done by comparing this vaccine versus Prevnar 13, because as you know, Prevnar 13 was in the national program before the Indian vaccines came. So around 600 children received the current vaccine, Prevnar 13, and 600 children received the new vaccine from Biological E, and they were studied for safety and immunogenicity, used in a schedule of 3 doses primary, 6, 10 and 14. So this is the safety data. As you can see between the blue and the green bar, there is hardly any difference on the local side effect like induration, swelling, redness, pain, or the systemic side effect like irritability, fever, etc. So the vaccine was as safe as the existing vaccine. Now on immunogenicity, and I want to make you understand, I mean all of you practice but don't read the science, and I think it's good for you to see the science. Don't go only but what I say, Dr. Kasi says, or someone else may say. We may have a little bias in our views, but you should independently study a paper, at least the licensing paper you should study. And for studying licensing paper, as I said, the non-inferiority criteria established by the statistical department and by the WHO. So I'll just give an example. This is comparing, let's say, Biological E's vaccine on your first column The Prevnar 13, the comparator vaccine on the second column. And this is the difference between the two on the seroconversion data on IgG response. So you say for type 1, with the new vaccine was 90.6%, with the existing vaccine 93.3%, the difference was minus 2.7% in favor of Prevnar 13 over biological E. Is this significant? That is decided by this confidence interval. So you can see this confidence, which means it could be as low as -5 or it could be actually as high as plus 0.35. So far as this lower bound confidence interval does not touch -10, it is statistically not significant. So you see for each serotype, you can see here, you look at this confidence interval, they are all above -10. So the vaccine was licensed as non-inferior to Prevnar 13 serotype by serotype on IgG seroconversion, including the new serotype, of course, which are not there in Prevnar 13. So you put comparison, the minimum seroconversion seen for any serotype, which was here type 3 77%, and again now compare, and it should be above -10. Now, what about the titers? So on the IgG GMC, you see the ratio. Say again take type 1 as an example. With the new vaccine, the titer achieved were 1.7, with Prevnar 13 were 2.2, the ratio is 0.77, the confidence intervals are 0.67 to 0.88. Now this 0.67 should be above 0.5, which means the new vaccine should be at least half as good on titers compared to the old vaccine to make it non-inferior. And again you can see here for most of the serotype it is above 0.5. So again it met the criteria of non-inferiority. And for the two serotype, I mean, there was a massive response because they are there in the vaccine, and the titers was 2 to 6-fold higher as compared to the existing vaccine. But as I said, IgG is not the best way. What you should actually look at is the OPA or the functional antibody. So this is the OPA conversion. Of course, this is not a requirement of the licensing authority, but every company will do it because people like me and Kasi will dissect the data and tell them that we reject you scientifically, even though you might have a licensing, because you don't have a good OPA or a OPA study at all. So this is the OPA seroconversion between the two vaccines. As you can see here, no matter which serotype you look at, the bars are very similar. And for the extra two serotype, you can see more than 96-97% OPA seroconversion. And again, OPA titer, there are no criteria of non-inferiority, but generally you can see here the values are very similar between the two vaccine, including the two extra serotype where there is a massive increase in the OPA titers. So both on IgG and OPA, seroconversion and titer, non-inferiority met for the common serotype, and additional serotype, a superiority of course was shown by the new vaccine. Now the last part of cross protection of 6B versus 6A and 6A versus 6C, because that's the only difference between this vaccine and the Prevnar 13, besides the advantage of this vaccine having two extra serotypes which are futuristic point of view. So is it cross protection or no cross protection? So IAP SAVP says that in general direct protection is always better than cross protection. Absolutely true sentence. We know it. When 19A did not cross protect 19A. We know for HPV 16 and 18 short cross protection against 31 33, but nothing great and nothing long lasting. Beyond 4 years no cross protection. That's why you have HPV 9, on which I will talk in the evening. Typhoid conjugate, you know VI doesn't cross protect against paratyphoid. Influenza, every year the strain little changes and you need a newer vaccine. So whether 6A will be cross protected by 6B, what is the data? And that is what is important. So what will happen to 6A when you use this vaccine as compared to the vaccine containing 6A like the serum vaccine or the Prevnar 13? So the first bit of evidence that 6B cross protect 6A came from use of Prevnar 7 in 2000 in USA. So this is a study done by Dr. Cynthia Whitney's group. She was the head of the CDC looking after PCV when these vaccines were being made. Some extremely beautiful paper written by Dr. Cynthia Whitney's group and her students thereafter. And this, they looked at 4 years of use of PCV7 in USA. Mind you, PCV7 does not have 6A. So what happened to the efficacy? Overall efficacy was around 77%, and serotype by serotype 6A also 76%, with a good confidence intervals of 39 to 90. So already a cross protection shown which was very high, as good as for the other serotype from PCV7 data itself in the United States. Then looking at the real world data, these are the countries using Prevnar 7 followed by Prevnar 13. So you can see in Israel, they introduced Prevnar 7 and before Prevnar 13 came, the disease disappeared. Same in USA, 6A went up and then went down drastically before Prevnar 13 came. And same is for UK, Prevnar 7 used and the 6A disappeared before Prevnar 13. Which means 6A was completely cross-protected even in a real world data using a vaccine which did not have 6A. And again, if the same data of GSK paper where countries using Prevnar, Synflorix, and look at the remaining serotype, you had 19A, 22A, 33A, but you don't see 6A in a major way in any of these countries. So 6A does not feature here as there is 100% cross protection. And why? And this is a paper which I would recommend everyone to read if you are interested in science of vaccinology. This is from the doyen of vaccinology, especially for PCV, Dr. Ron Degan. And he's from Israel. This is the paper he actually reviewed data on several studies done on OPA titers using PCV7, PCV10 of GSK, PCV13 of Pfizer, and comparing Synflorix versus the Prevnar 13. And you can see here, just to draw your example here, when you compare Prevnar 13 with Prevnar 7, I showed you there was a 66-fold higher, 10-fold higher titer with Prevnar 13 compared to Prevnar 7. When it came to comparing Prevnar 13 versus Synflorix, there was 77-fold higher titer with Prevnar 13 compared to PCV10 of GSK, and yet using PCV7 or PCV10 of GSK, there was no breakthrough on the 6A disease. And you compare this new BE vaccine with Prevnar 13, there was just a 3-fold higher titer with Prevnar 13 compared to PCV14. So when a vaccine with 77-fold lower titer or a 10-fold lower titer almost showed 100% cross protection, why would a vaccine not having just a 3-fold lower titer not work against 6A? So it means the 6A is going to be taken care by 6B, and that was the IPD. What about the non-IPD? If you say the titers are lower, mucosal infection may not be covered, carriage may not be covered, so herd effect may not be seen. So let's look at one by one. This is non-invasive disease, otitis media. This is study done in Finland, where for every child with otitis media, they do a myringotomy and send the pus for culture. And what they looked at the efficacy of Prevnar 7 against the serotype and non-vaccine serotype. And you can see here, overall efficacy against vaccine serotype was 57%, and that against 6A was also 57%. Which means there was 100% cross protection by 6B versus 6A, even for a non-invasive disease like an otitis media. This is not just one country, but also from Israel, Dr. Ron Degan's group. They introduced PCV7 somewhere here. Then the red is the PCV7 in the national program with high coverage. Then switch to PCV13 gradually, and then high coverage of PCV13 in the pink color. And you can see here, this is looking at all AOM caused by PCV7 plus 6A, and you can see here before Prevnar 13 was introduced, the disease had disappeared and continued to remain low after PCV13. So again, one more country showing you that otitis media is completely protected by a 6B containing vaccine as far as 6A is concerned. And the last part is on the carriage. So this is a study done from France. They were very peculiar study, 8 pediatric hospitals which look at 10% of the pediatric population of France. They have this trial done where they looked at a carriage done, nasopharyngeal carriage in a child with otitis media. So child has otitis media, but they also look at the nasopharyngeal carriage for the pneumococcal serotype and see what is the difference. So they had children who had received either PCV7 or children who had received PCV13 during the study period time, and what was the carriage seen in these children. And you can see here, the blue is PCV13 children, the green is PCV7 children, and these are the different serotype as general. So you can see here, as far as 6A is concerned, there was absolutely no difference between PCV13 and PCV7 children, as there was no statistical significance. So again, carriage comes down drastically when you use a 6B containing vaccine, even for 6A. And that reflects on the herd effect. So on your right is the children above the age of 5 years and adults. And again, the same story, countries using PCV7 before and then switching to PCV13. You can see in Israel, before PCV13 came, there was a great reduction in the 6A disease in people who had not received the vaccine. More seen in USA, you can see here, 6A just kept on going down, almost zero before PCV13 came, and same for UK, it went up with PCV7 and then went down before PCV13 came. So you also have a massive herd effect seen as far as 6A is concerned by a vaccine which does not have 6A. Now why this? And that is because 19A, if you say 6A, you need 0.16 microgram per ml of antibody compared to 19A where you need 1 microgram, 6 times more. That's why 19F could not cross-protect 19A, but 6B is able to cross-protect 6A because the titer required are very low, which are inducible by 6A. Now the question of the WHO paper also said that if you have 6C, then you should use a 6A containing vaccine. So when this vaccine does not have 6A, what will happen to 6C? So we said the 6B will cross-protect 6A, but what about 6C? So this is the paper again from USA, 7 years of use of Prevnar 7, which did not have 6A. What happened to 6C? So the 6C went up from 0.09 to 0.5 in children, from 0.2 to 0.6 in adults, overall from 0.2 to 0.6, which means it is still less than 1 per 100,000 population. So which means the disease in 6C is not as prevalent as we see. In our country, there are no studies on 6C as far as IPD in children is concerned. So maybe if tomorrow you see that 6C is really a high disease burden, then this vaccine is not going to work. But as on today, we don't have any evidence to say that there is enough 6C in our country. So can you use this in 3+1? So there's a toddler data where they compared naive toddlers using either this vaccine 2 doses 8 weeks apart or Prevnar 13 8 weeks apart, and you can see seroconversion between the two was the same between the Prevnar 13 and the new vaccine. And there are ongoing studies which are looking at especially this phase 4 trial where they're going to go 3+1, 6, 10, 14 weeks, and a section of these children will also receive a booster during second year. So till the time this data is available, I also believe, IAP also believes that we cannot recommend this vaccine as a booster dose. But hopefully children who are receiving primary series now will be eligible for booster next year. Before that the data will come and probably will be able to use this vaccine also as a booster, as is done for the serum's vaccine, because serum has a study on booster use in Gambia. This vaccine is not used in any other country, so we don't have data in our country either or in our outside country. So this data will have to come to tell us that we can use this as 3+1 in our day-to-day practice. But what suppose the data doesn't come? Then you will have to use any other vaccine as a booster dose and not use this vaccine till the data is available. Alright, so this is the serotype coverage -6A. Okay, first -6A. So you can see Prevnar 13, the serum's vaccine and this new vaccine are having very similar serotype coverage in all these 4 data set as compared to GSK's vaccine. Because it does not have 6A and 19A both, the serotype coverage is less. But as I said, because there is near 100% cross protection for the 6B versus 6A, and you give that additional advantage to this new vaccine, then it becomes in yellow 74, 79, 77 and 79. So it is a little edge over because it also has 22F and 33F. So to conclude, this new vaccine has 19A, 22F and 33F -6A. It has undergone systematic trials comparing with Prevnar 13 both in children 6, 10, 14 weeks and in toddler, found to be as safe as immunogenic and has advantage of 2 extra serotype. At present, the ongoing trials are for the EPI schedule of 2+1 and the schedule that we want in practice of 3+1. The data will be out soon, and that will make us help better take the decision as to what to do for the booster dose. So it's another made in India vaccine, and I become very happy when an Indian vaccine comes which is good and effective. So we witnessed this Chandrayaan live very, very nicely, and NASA actually asked India that you could make something which goes to Chandrayaan like ours at 1/10 the cost. What is the success story? I think the same story we have to ask our vaccine manufacturer who make excellent vaccines which are life-saving at almost 1/10 the cost of an international market. Thank you very much.
Delegates, kindly note that the distribution of delegate kits will take place not during this tea break, but after the tea break. And just hold on for a moment. We have something really interesting coming up. Can we have that first video, sir? And while we watch this video, we know that IAP Mumbai is appealing to all of you, sitting here in this audience and otherwise, to use growth charts in our practice.
Friends, growth chart is the progress card of health, and every child should have it being monitored till the end of the growth. Periodic growth monitoring can pick up an early deviation that could be the only clue to a hidden disease or a defect, and it gives you an early diagnosis. In day-to-day practice, the growth chart helps us to define correctly the origin of the disease, because many times the parents present with acute symptoms, but behind that could be some insignificant symptoms overlooked by the parents, and we can pick up by the growth chart a subacute or a chronic illness, though presenting apparently with an acute symptomatology. Of course, duration and progress adds to the probable etiology, and the diagnosis can be helped. The difference between a recurrent infection and a persistent infection with a recurrent symptoms like tuberculosis can be easily made out by the growth chart itself. And finally, parents are always worried about their child being thin, and a growth chart keeping up the centiles can really assure the parent that their child is quite healthy. Friends, growth chart has a very positive preventive role and also a diagnostic ability. It is so simple, it's most useful, and it is cost effective. Friends, if you are not doing it so far, please take a pledge and start doing it. After all, we all want to be rational pediatricians. Thank you.
Friends, growth monitoring is a routine practice for all of us as pediatricians, as it provides us with crucial clues to make diagnosis of certain conditions. Growth monitoring, which includes monitoring of head circumference up to 5 years of age, length or height, and weight monitoring, is equally important in hematology-oncology practice. If there is an acute weight loss accompanied by fever and/or other symptoms and signs, one must suspect malignancies such as leukemias, lymphomas, and/or solid tumors. An early diagnosis coupled with early institution of appropriate therapy definitely improves outcomes in these children. In a child with iron deficiency anemia, if there is growth faltering, both weight and height, one must worry about malabsorption syndrome such as celiac disease. In certain chronic conditions such as hemoglobinopathies, we must monitor height regularly to derive height velocity. And with that, one can diagnose whether the child has short stature due to pituitary and/or gonadal iron overload. Timely appropriate intervention in such children can help treat short stature to attain better final heights. Anemia of chronic diseases such as anemia due to chronic renal or hepatic disorders almost always is accompanied by short stature. A preceding growth chart is a great help in diagnosing these conditions. Friends, one cannot overemphasize the importance of growth monitoring in each and every child that visits our clinic. Let's continue this practice as we have been doing in the past too. Thank you.
Most pediatricians recognize kidney diseases by the symptoms of puffiness of face, oliguria, hematuria, or massive proteinuria. However, only 20% of children with kidney diseases present with this obvious symptoms and signs. The majority of children, over 80%, have subtle symptoms and signs not easily attributable to the kidney, and hence kidney diseases often go unrecognized and undetected in the early stages and are detected very late. An important feature of all kidney diseases is failure to thrive and a poor statural growth. Hence, growth monitoring using growth charts becomes a very important tool to identify those selected children who may benefit from a deeper evaluation to find out the presence or absence of kidney diseases. weight less than the 5th centile or a falling weight centile, height less than the 5th centile or a low height velocity, or a height curve which is falling below the mid-parental height curve, would give a clue to which child should be investigated. So I would suggest that growth monitoring using growth charts should be used in all children.
So dear friends, let's join this movement with Team IAP Mumbai. Let's start using growth charts in our routine office practice and pick up all those faltering growth curves and offer early intervention and early referrals for all our patients. Let's become rational pediatricians. Thank you. So dear delegates, there is one more D to our conference today, Vaccine CME with a difference. And there's a sincere appeal from the entire team of IAP Mumbai that please start using growth charts as we see that multi-speciality. Let our file from IAP Mumbai members go out with growth charts wherever it goes, anywhere in the country. And today, whosoever wishes to get complimentary growth charts, we have 6 of them, 3 for girls and 3 for boys in between 0 and 18 years, 5 to 18 years, and BMI charts from 5 to 18 years for both the sexes. Kindly give your names at the registration desk with Nilesh or Vinod, and we will see to it that we will get it delivered to you. Thank you very much.
And because of the stupendous success of the Indian cricket team that we all were witness to history yesterday, Dr. Bipin Shah has wanted to celebrate it with all of us here. So may I request Dr. Nitin Shah, Dr. Nehal, Dr. Chokhani, Dr. Kasla, Dr. Amruta, Dr. Shikha and Dr. Bipin Shah to come on stage. And with all of us there, let us give a big round of applause to the Indian cricket team, to Team India.
अपना है दिल ये आज का, दुनिया से जाके बोल दो, बोल दो, ऐसे जागो रे साथियों, दुनिया की आंखें खोल दो, खोल दो, लहरा दो, लहरा दो, सरकशी का परचम लहरा दो, गर्दिश में फिर अपनी सरजमी का परचम लहरा दो, लहरा दो, लहरा दो, सरकशी का परचम लहरा दो, गर्दिश में फिर अपनी सरजमी.
Thank you everyone, and a big round of applause here. I request everybody to not collect the delegate kits right now because they're not available. It's going to be available after the tea session. So please, you get 15 minutes, against your coupons, and you get 15 minutes to finish your tea and come back here, back in time for the next sessions.